All right, everybody, we should get started. We're 5 after the hour. So, welcome. Okay, thank you all for coming here. We're going to be talking about how to think critically about heme and heme malignancy studies. And I just want to introduce a few people. So, of course, you know me and Aaron. So I'm Vinay Prasad. I'm a professor at UCSF. I take care of everything every week in clinic at the General Hospital. That's everything from benign hematology von Willebrand's, iron deficiency, to ET, MDS, Hodgkin's, non-Hodgkin's. It's kind of like a county hospital. We got to see everything. And I also do some solid tumor too, some people may know. And I'm joined by Aaron Goodman, who is also known as Papa Heme. And this is his hometown of San Diego, and he's been showing us all the great taco stands. And Aaron is, of course, associate professor at UCSD. He is a heme malignancy expert, and he is a transplanter, which means he knows you need a transplant. If you have intermediate risk AML, you definitely need that allo transplant, and he's going to talk about that and other fun topics today. And we're also joined by a special guest. Oh my God, how did he get up there? This is Manni. Yeah, that's why I was smiling at you earlier. Yeah. Manni Mohyuddin, assistant professor at Huntsman, University of Utah, and he's going to hold our feet to the fire for everything myeloma, but we also got Raj too, so we got a lot of people. This is a tough audience. If we say anything wrong, we're gonna get in trouble up here. So before I really get started though, I'm curious about all of you. So, what's your backgrounds? Okay, I'm gonna give a few categories, and if it applies to you, maybe put your hand up. Okay, so I know there's a few people here from industry. Is that the case? Anyone from industry? Okay, great. Thank you so much for coming. We'll take it easy on you all. Is anyone here from insurers or PBMs or other? Okay. Anyone here who works as a mid-level or a nurse practitioner or PA? Okay. Anybody who is an oncology or, hematology attending? Heme attendings, okay. And people who are heme fellows? Okay. And any residents? A couple. All right, so we got quite a crew here. And then let's do geography. Who's from North America? Okay, almost everybody. Anyone from Australia? Yes? Oh, good. We're in Australia. Sydney. Okay, of course. Beautiful place. Okay, anyone from South America? Asia? Yeah, okay. Where are you coming from? Japan? Yeah. Okay, great. And then anyone from Europe? Okay, a couple of people. Huh? No, we got a few people. Where are you from in Europe? Norway, okay, good. Well, you know, I'm always biased because I think a lot of the European nations are already much more sensible and think clearer than the United States, where we like to spend a lot of money, and maybe occasionally we get something for that. All right, so I have to kill. My job was to kill the first 20 minutes to let people come in. So I'll kill the first 20 minutes, but then you're in for the real show because Aaron has picked abstracts. He says these are the abstracts that you need to know in this meeting. You could skip every other session, you could see these abstracts, and he's going to walk us through what's good and bad about these ASH abstracts. So we're going to do that in about 20 minutes. But first, I'm going to waste your time a little bit to allow people to come in the room, and I'm going to talk a little bit about some things I think interesting about our studies. All right, I want to start by saying something that you hear very often these days, which is what do we actually care about at the end of the day? We care about patients care about, doctors care about. What we should care about is living longer. We want to improve overall survival and living better. And what does living better mean? To me, it means improving health-related quality of life, not just for the next 6 weeks or 12 weeks or 4 months when you measure it, but for the duration of your cancer journey. And I think that's the goal of oncology care, to improve survival or to make you have a better life experience. And there's no other goal. And here's what I think too many people at ASH care about, which I don't think we're supposed to care about. They care about depth of response. Depth of response, maybe, insofar as it affects the first two, but in and of itself, it's a meaningless commodity. MRD levels. I think to date, in every malignancy, MRD is still, and what is it, minimal residual disease, or is it measurable? Oh, of course. Oh, how could I forget? That important change, measurable residual disease. It's prognostic, meaning that if you have less disease measurable, you're going to do better than if you don't. But is it a surrogate? In other words, do substances that drive MRD levels better, do they make people live longer, live better than substances that don't? That's the question of surrogacy. So that, to my knowledge, has not been shown in any malignancy to date. And then finally, is it actionable? Can you do something different in MRD positive versus negative? There are lots of people who will tell you in ALL, if they're MRD positive, we do this. If MRD negative, we do that. The gold standard for predictive biomarkers to show me that if they're MRD negative, they don't benefit from a certain therapy, but if they're MRD positive, they do benefit. So you have to sort of randomize both groups of people. And that's, we have a little bit of that kind of data and some of that data to come. So I think MRD is in its infancy. Shiny new drugs and more drug approvals. I always hear people say, we're doing such a great job, we've approved 30 drugs this year. I say the measure of doing a great job is not how many drugs you approved. It's the first two things, okay? Quadruplets and continuous therapy. Myeloma doctors like to tell me the best time to start treatment is as soon as possible, forever with as many drugs as possible. And in fact, there's a new study that we're going to be launching that actually you've heard about the fluoride, it might be taken out of the tap water. We're going to replace it with Revlimid and measure time to MGUS in the population. So we're working very hard to put time to MGUS as the endpoint it deserves to be. Who wants to reduce MGUS? Both of you in your myeloma clinic. No, you cannot get any more neuropathy referrals for MGUS with Revlimid in the water. All right, cellular therapy, novel targets. I mean, to me, the mechanism of action doesn't matter. All I care about is how good is the drug and what are the side effects and what are the costs. Publications in journals and posters. Posters to me are a thorn in my side because they take up all the overhead bin space. Publications don't matter. I mean, this is really what patients care about. We're talking about all this stuff. Opening new trials, consulting payments. To be honest, somebody told me that ASH is my best week of the year. I make more money than I make the rest of the year because they're doing all the ad boards. Good. See, my killing time is working. This audience is picking up. All right. Oh, and the most important. For the next 45 minutes, there is an unlimited open bar. At 45 minutes from now, it will be a cash bar. And this is not pharma funded. All right. So I think when you look at the landscape of clinical trials in hematology, hemalignancies, multiple myeloma, Hodgkin's, I think sometimes we're not answering the most basic questions. We're answering questions that the industry has decided is the agenda, that a lot of people have decided the agenda. We're not answering the most basic questions. We have big problems in our studies. The most basic questions: when should we approve drugs? What should be the bar for drug approval? When should we treat people? Should we treat them when they're asymptomatic with early precursor disease? How do we sequence these drugs? These sort of fundamental questions, I think, get a short shrift in this conference and even in the cooperative groups, so I don't think they answer these questions satisfactorily. So let me walk you through it. I'm going to pick on multiple myeloma, my favorite malignancy, in part because I've got Raj here, I've got Manni here, I've got the myeloma experts here. How do multiple myeloma drugs come to the US market? If I was in the drug industry and somebody comes to me and they say, we got a new compound, okay? We want to get this FDA approved in myeloma, what would I advise them? First thing I'd say is, well, does your drug have single agent activity? If you take a bunch of people with multiple myeloma and you give them the drug, you give it to 100 people, is there a 20 or 30 or 40% response rate? Do you drive down the M protein? Do you clear the marrow in some fraction of people? Because if the answer is yes, then you've got a path to the US market real easy. You've got accelerated approval. And all of these drugs we talk about, teclistamab, Elra, talquetamab, Selinexor, belantamab, melflufen, Idacel, and Cilta-cel, they all came to the US market on the basis of uncontrolled studies where we administered these drugs typically to people who have taken other myeloma drugs, and they have some response rate. So that's, if you got single agent activity, you got a path to the US market. And if you can get about, 20%, we'll take it. 20%, you're in. In solid tumor, maybe 11%. We can't be asking for 20. In Hodgkin's, a stiff breeze has an 80% response rate, but what did you say?
So Selinexor by itself had a 4% response rate. This was Selinexor
and Dex. That's fair. That's fair. That's the other thing. If you want to boost your response rate, a little Dex, a little vitamin D. I always say multiple myeloma treatments are like going to Chipotle. You get a burrito bowl. The first thing you put in the bowl is the rice. That's a steroid. You either need a Dex or you need a Pred, right? Then you can choose any of the other things. You can choose an IMiD. You can choose a proteasome inhibitor. You can choose a BCMA antibody or target. You can choose a GPRC5D. You can choose a nuclear export inhibitor. And pretty much any combination of these things. And you can choose an alkylator. Let's not forget about alkylators. And if you do an alkylator plus bortezomib plus Dex, what's that called? Cyborg-D. And if you do bortezomib, melphalan the alkylator, and prednisone, what's that called? VMP. And if you do CD30 antibody Dara, Revlimid, and Dex, who did a study of Dara RD versus RD in the frontline myeloma? What's that trial? Maya. So pretty much, it's like a Chipotle burrito. Put a little steroid in that, and then pick any of the other categories you want. You got phase 2 or phase 3 in either the second line or first line. Okay, so if you have single agent activity, and if you don't, add a little dex, and if you do, you come to market. But what if you don't? What if you really? Oh, one point I want to make. Everybody quotes those response rates for CAR T, but Manni will be the first to tell you that that CAR T cell is the response rate in everyone who got those cells going into their body, not everyone who had the cells collected. And if you actually look at the intention to treat response rate, both ide-cel and cilta-cel drop a little bit in the initial studies. Well, 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 Eduardo, just like our meetings, better late than never, huh? Better late than never. Okay, so for CAR T, Manni's point is in this paper that intention to treat response rates are about 8 to 12% lower. So when you're going to compare a teclistamab against a cilta-cel, and people comparing response rates, well, at least teclistamab is using an intention to treat response rate because there's not all these people who failed to receive the product, teclistamab. So I think that's sort of a more balanced comparison between these BCMA targeting products. But listen, if you don't have single-agent drug activity, you still have a path to market. Let's not get hopeless. Let's look at the experience of panobinostat and elotuzumab. Both of these drugs came to the US market without single-agent activity. This is the Kaplan-Meier curve of panobinostat. As you can see, there's the old saying in oncology, if you can fit the laser pointer between the curves, you can give the plenary session. And here you can fit 5 or 6 laser pointers in this PFS curve of panobinostat. Now, panobinostat, of course, is a terrible drug that has terrible toxicity. And even though it was FDA approved initially on the basis of this data, it was ultimately withdrawn by the manufacturer. That's a euphemism that means FDA said, you better do something soon or we're going to take care of you. Oh, elotuzumab. It's such an interesting drug. What's the single agent response rate of elo? 0%. And every once in a while it has a benefit in a study, but I'm aware of many, many elo studies where it doesn't have a benefit. I suspect that the p-value, which is the probability you would see this result or more extreme result, assuming the null hypothesis that this doesn't work, I suspect the entire portfolio of elo studies can just be explained by the false positive rate of repeatedly trying a drug that doesn't work. There are going to be some false positive successes. That's my suggestion for ELO, to adjust the ELO studies for the portfolio of studies, because I'm not convinced it does anything. So this is ELO. Not so good in my mind. You still give it? No, well, of course, we'll never say never. Very rarely, okay. Oh, this was a good one, pembrolizumab. Pembrolizumab improved PFS in myeloma. Oh, but unfortunately, overall survival is worse. Okay, so checkpoint inhibitors have no role. And venetoclax. I keep hearing it has a role in 1114, but no matter how many times you do the study, it's still negative, negative, negative. First, it had a PFS benefit in all comers with an OS decrement, and then in 1114, it's still not statistically significant, and FDA hasn't given the approval, but there's still people who benefit, I hear. So I hear. All right, what about melflufen? Melflufen's great, because if an old alkylator falls off patent, you add a little peptide on the end. You just toss a little peptide on that, you get a new patent. And melflufen, which is an alkylator, attached to some little peptide, you can see the difference here. This is melphalan, and this is melflufen. And this is like the secret ingredient that makes it really, really good. So I heard. It's like totally different than this. Totally. And it was approved originally based on uncontrolled data, Horizon. But later, on July 28th, just a few months after the original accelerated approval, the Oceans Phase 3 FDA alert came out that there actually is a survival decrement. It's a decrease in survival against what control arm, Manni? Pomdex. Is that the gold standard control? I mean, perhaps some would argue it's an acceptable standard, but that's a weak control arm, and this is a survival decrement. And then it took them another few more months to withdraw the product. So my concern with this timeline is that why do you need to jump the gun and approve a product for 4 months when you're going to get the OS data imminently? To me, it reflects an unusual exuberance by the FDA. And this occurred despite the substandard control arm in Ocean. The new compound was derived from a parent drug. It wasn't very novel. The accelerated pathway was used, and the accelerated pathway arguably harmed patients, anyone who got this drug in those few months. Now, of course, the overall survival was shorter if you got melflufen, but the company says, well, listen here, the PFS among people who didn't get a stem cell transplant in the first 36 months, that's actually better, huh? And then the FDA pointed out, well, you know, that people were randomized in March actually did better with melflufen, but people randomized in July did worse. So I think subgroup analyses should be taken with a grain of salt. A grain of salt. Oh, and even the ODAC voted against him. That's tough when you lose the ODAC. Oh, Dream 3. Let's talk about Blenrep. Belantamab mafodotin. It's tough on the wallet and tough on the eyes. They say tough on the eyes. It's tough on the eyes. And it actually was FDA approved based on response rate, but very soon thereafter, Dream 3 showed that it did not, in fact, have a PFS benefit against POMDEX, and it had tons of grade 3 keratopathy. It's an ophthalmologist's dream to get all these appointments. And the overall survival was not improved for belantamab, and of course, it was withdrawn. Now I hear we're going to see that Dream 7 is positive for OS. I hear that's happening this weekend. And Dream 8 is also looking pretty good. So Bela might yet come to the US market. I suspect it will come back to the US market. But my question is the following. In the years that have passed, a lot has changed. In this trial, I bet the only BCMA-directed therapy that these people ever receive in Dream 7 is going to be belantamab mafodotin. Does Bela have a role when we have so many other BCMA-directed therapies? And I think it's completely almost an irrelevant study for where we are now with teclistamab and cilta-cel, et cetera. So I'm not convinced it's going to have much of a role, and I'm not sure how actually, I do have a speculation. I bet very expensive places like, the Sloan Ketterings of the world are going to move to a model where you get your CAR T first and then you get your teclistamab. And you want that order because you can give both. And then if you live in kind of like a suburban hospital and you're a little wary of CAR T, I think you give a teclistamab, okay? But if you're really out in a rural hospital and you don't got a lot of support, well, then you give a belantamab. So I bet you'll have extreme regional variation in the practice patterns around BCMA-directed therapy.
We could publish a paper about the disparity.
We'll come to that. I could publish a paper about that. Maybe even a plenary. Oh, the Boston study. The Boston study was a very interesting study. We took that novel drug Selinexor, and people kept telling me it had a novel mechanism of action. You still felt like crap, but it had a novel mechanism of action. And among people who had prior therapy, a lot of them had already gotten proteasome inhibition before they enroll in this study. And then they randomized them in Boston to Selinexor, Velcade Dex versus Velcade Dex, even when you've already just gotten Velcade. And that to me is a problem. And so we wrote this letter. It says this: given that bortezomib and dexamethasone has been shown to be inferior to contemporary treatments in trials well before Boston began enrolling, why did Sebastian and colleagues consider bortezomib and dexamethasone an appropriate control arm for patients in the US, and why did it enroll in the US? And Aaron Goodman said this on Twitter: Boston, Journal Club. He says it fulfills, is the next one? Yes, Boston fulfills Goodman's pentad for bad randomized trial. Goodman's pentad. Number 1, PFS is the primary endpoint. Number 2, substandard control arm. Number 3, the PI with conflicts of interest from the sponsor. Number 4, an expensive drug. And number 5, inappropriate use of crossover, because they just got more Dara after the fact in the control arm.
Got 46 likes.
Yeah, you were. Should have posted on Blue Sky, my friend. All right, I'm going to skip that. We celebrate CAR T so much, but when we first saw idacaptogene, we calculated that knowing that everyone progressed. I think one thing we don't point out with CAR T and myeloma is the bar has shifted so profoundly. In 2014, when Kokendorfer was doing the early studies, people thought CAR T myeloma would be a curative treatment. We've walked away so far from that hypothesis. Now we accept for granted that no CAR T will ever be curative and 100% of people will relapse. That's a huge erosion in what we thought CAR T would do in this disease. It's a big disappointment. It doesn't get talked about enough. At the price of ide-cel, in the original study, even if you assumed the entire PFS was due to ide-cel, you're talking about $40,000 per month because it was so costly. So it was already something that would be at the cusp of what would be affordable. That's at least ide-cel. Cilta-cel maybe a better PFS. I think in oncology we have this narrative that we have to live in the system we live in, where drugs are initially approved based on uncontrolled studies and randomized trials later come, because if we waited for randomized studies, it would just take too long. We don't have time to wait. And I want to point out here, this is how long STORM, which is the uncontrolled study of Selinexor, took from the first patient was enrolled until the first result was presented, 38 months. This is how long Boston took, the randomized controlled trial. This is how long melflufen took in Horizon. This is how long OCEAN took. And if you look at all these myeloma studies, a pattern emerges that actually the difference in the time from an uncontrolled study with a couple hundred people and the difference and a randomized study is actually not as much as you might think. They're actually much closer together than you would think. And the reason people forget is you're all thinking about individual patients. An individual patient, first they respond, then they progress, and then they may die. But in a randomized study, something different happens. You have a period of enrollment. You enroll people over time. The responses come all a long time. You have to wait for them to respond. There's a median time to response. And then you don't just approve the drug when you've got the response rate. You have to show the responses are not completely fleeting. You have to measure the median duration of response among the responders. And the time is getting longer and longer and longer to capture both response rate and median DOR. You have to wait for them to respond and then wait for them to have the median duration of response, because FDA doesn't approve things with fleeting response rates. They like to see at least not reached or 16 months or some DOR. In a randomized study, from the moment of randomization, you can always assess the endpoint. The reason Horizon stopped so quickly is that OS was so bad. Ocean stopped so quickly. OS was so quickly bad. So in some ways, randomized studies are actually for when event rates occur very fast, they actually occur very briskly, and the difference is less than people think. So we actually did a study, Emerson Chen and I, where we used sort of a very complicated sort of regression analysis to estimate how much time do we save by accepting the surrogate endpoint. And we looked across many, many studies, acknowledging that trials have an enrollment period and a time to primary analysis period. And what we found in our study, boy, I guess the simple answer is that when it comes to latter lines of therapy, like third or later, there is no time savings from response rate. In multiply relapsed populations, overall survival is occurring so briskly, you don't save time. And actually, the time savings in the whole cohort is 11 months out of a 9-year drug development process. So I'm not going to say there's no time savings. There is a time savings. That savings is modest. It's less so in refractory populations. And it might not be worth the trade-off of the uncertainty. Myeloma is a field actually where the batting average is very high. But if you look across oncology, the batting average is much lower for the probability that a drug that's initially approved later shows OS benefit. All right, we don't know when to treat. So, I always like to draw this. I always imagine the bone marrow as a spectrum from 0% clonal plasma cells to 100% clonal plasma cells. And there's the old saying in Plato's Republic that said, the role of science is to carve nature at the joints. Biology exists on a spectrum. We're the ones who've decided what's MGUS and smoldering and slim and blah, blah. We decide that. But biology exists on a spectrum. And on one end of the spectrum, you have people whose marrow is caked with disease. They've got painful bone lesions. They're anemic. Their calcium's through the roof. They have kidney failure. That's historic myeloma. On the other end of the spectrum, you've got people who walked into a Dana-Farber clinic and they've got MGUS. They went the wrong doorway and they have a MGUS. They got, oh my God, I just had little pins and needles in my hand. I slept on it funny and I got MGUS, I got MGUS now. Okay, so we define MGUS as 3 grams per liter and plasma cells, and smoldering is this or that, this is this and that. And then we put this line, we say myeloma is defined as like people with end organ damage. There's a definition of myeloma. And we know from old randomized studies, if you randomize these smoldering people back in the 90s to like treatment, no treatment, there's no survival benefit, and they get more time on treatment, and there's no quality of life benefit. And these people, we think we should treat them because like the end organ damage is just going to get worse, and we can kind of control that. And then in 2014, the International Myeloma Working Group comes along and they say, well, the definition is all wrong. Let's draw the definition over here. Anybody with 60% plasma cells in the marrow without any end organ damage, anybody with MRI findings of myeloma pockets in the bone, not X-ray radiographic findings, and anybody with a free light chain ratio that's extremely skewed with a certain baseline free light chain ratio is defined as also having myeloma. So they've changed the definition. When you change the definition like this, even in the absence of any improvement in therapy, you do 2 things. One, okay, we move the definition. The 5-year survival benefit goes up in smoldering. It goes up in smoldering because you're removing the worst actors from the smoldering category. And what happens to the 5-year survival benefit in myeloma? It also goes up because you're adding in people with the most indolent biology. So when people show me these figures of in myeloma, we've had such a great last decade because the 5-year survival was blah, 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 now it's blah, blah, blah. I say, sure, I'm happy to concede that probably 60% of that is the drugs. Maybe some percent of that is improvements in supportive care. And some percent of that is because you guys keep changing the definition, okay? And soon they're going to be, I don't know, they're going to go that, I think they're eyeballing this. Because the more this arrow goes this way, the more revenue. I mean, it's a lot of revenue that comes from these decisions. And this is the quote by Will Rogers, because Raj wrote this great paper, Will Rogers Effect. When the Okies left Oklahoma and moved to California in the Great Depression, they raised the average intelligence in both states. And the point is that by moving somebody from one set to the other, you can actually improve outcomes in both sets, artificially. You're not done anything. All right. So in the original logic to why is that free light chain ratio used as a myeloma defining event, they show data from the Mayo Clinic group that shows that if you had exquisitely skewed free light chain ratios, you were extremely likely to progress to myeloma. I always pointed out that even by their own data, there's a good chunk of people 2 years later who were never going to get myeloma, even by their own data. But since then, so much data has accumulated that the new prognostic implication of free light chain ratios is not as bad. And what I've done here is I've actually got the time to line up. This was the original Mayo Clinic data. We're talking about at 3 years, maybe 85% of people progressed. With modern staging, where we're removing people with PET-positive disease, and looking for this disease so hard, you find that about half of people haven't progressed with just exquisitely skewed light chain ratios. We're medicalizing an asymptomatic precancerous condition, giving people so much more of their life on very toxic teratogenic drugs, and we have never done even one randomized study proving that treating these people has any long-term improvement in any outcome. We talk so much about smoldering and the flawed studies there, which we'll talk about, but if you change a definition, it's a lot easier than actually running more randomized studies. So they can just change high-risk smoldering to call it myeloma, and then people will change practice. This is, I think, who here watches these patients and doesn't treat them? Yeah, I don't treat them either. All right, so that's high-risk smoldering. For the sake of, sometimes I hear people say that this study showed that treating smoldering has a survival benefit. The point I always make about this study, this is the Jesus San Miguel study, this phase 2. There's 50 and 60 people in this study. The primary endpoint is not overall survival. It's not designed or powered or suited for overall survival. It also, PET-CT wasn't done at baseline, so they probably also included a bunch of active myeloma. The primary endpoint was PFS. That OS is so noisy. And only 8 people on the control arm ever got lenalidomide in their treatment journey. So yes, understaged, substandard post-progression treatment, and underpowered, waiting for a spurious p-hacked result. Yeah, okay, it works then, but it doesn't really replicate. Some people talk about ECOG as justifying treating high-risk smoldering. In the ECOG study, they did a good thing. They randomized people to len or observation. The primary endpoint was PFS. That was a win. And they actually, in the original protocol, specified that OS would be the key secondary endpoint. But then the investigators had a protocol amendment and allowed people on the control arm to cross over if they so wished, muddying the waters for OS. So we'll never know if treating high-risk smoldering has an OS benefit. And then we're going to talk about today the Daratumumab study. All right, so myeloma definition, I don't know. I think the definition needs to be explored more. I don't think we even know what for 1,000 randomized trials in myeloma, and no one can tell me who should be treated. That's my point. We don't know how to sequence drugs. Everyone's always telling me quadruplets are better than triplets, and we're going to show some nice survey data from Manni today. But I think we do have drugs that actually work in myeloma. I am confident that the approval of these products has improved survival. Proteasome inhibitors actually improve survival. CD38 targeting actually improves survival. And IMiDs actually improve survival. I'm totally confident. I just think we have no idea of how to use them. Should we get quads? Should we do triplets? Should we do triplets in third line? Every single one of these studies that we hang our hat on have deep problems. And the biggest problem is they don't have subsequent therapy that looks at all like what our practice was in the US at the time the study ran. That's a big problem. Bad control arms is one problem. Of course, Seli, Velcade, Dex versus Velcade, Dex in somebody who's already had Velcade and about to have more Velcade. Oh, what kind of study is this? What are we even doing? It's not answering anything useful. This is Manni, again. The control arm regimen was considered inferior if a previous randomized trial had already established a PFS benefit, and Manni finds, what was the answer? Out of 49 randomized trials, 14% of trials enrolled patients on an inferior control group after existing regimens had been published results. 18% enrolled onto bad control arms after data emerged during the period. They could have had a protocol amendment. We can debate whether or not that. And here's the key. 75% of these studies had one of the same investigators. The same author was on the study with the bad control arm who developed the correct control arm. So they can't say they don't know. There's only the same people. They're on all the studies. They know what they're doing in their clinic. And they know they're doing a bad control arm. All right. Bad post-protocol therapy. Again, Manni, he looked through all of the a bunch of randomized control trials in myeloma, and he shows that one thing is only about 40% even tell you what happened after the trial. Like, if the question is, does everyone need a quadruplet up front versus triplet, and is there survival benefit for, say, in Perseus, which I think there will, I mean, I don't know exactly, it's not been reported yet, but some people think there'll be a survival benefit in Perseus. But the question is, in the control arm, do you eventually get DARA? How many people get DARA? And they run a global trial where a lot of countries, unfortunately, cannot afford DARA. And if they can't afford DARA on post-progression therapy, they sure aren't going to be able to afford DARA in the frontline setting. And we find that most of the time they don't even tell us this data. And when they do tell us this, and the majority of people treated, we just have no idea. Among those that do report it, I forget off the top of my head, do you know what it is? About,
It is very low.
Very low.
Like, if you look at the DARA trial, the Maya trial, DARA Lendex versus Lendex, the control arm, when they progressed, only 28% of them ever went on to get DARA.
Yeah. And now here's a figure of like just the DARA results, like across studies. Like among people getting treated with DARA moving up front, what percent get crossover to DARA? And it's very low, and it's not reported for so many. Okay. Solutions? I don't know. I mean, I'm the only person who thinks that, like, I think we have to be very cautious about what, like, I support accelerated approval pathway. I think in diseases that are truly very dire, very rare, and with few treatment options, there needs to be a pathway that quickly brings drugs to market. But I think if a disease starts to become more common, if the outcomes start to get better, and if you start to have 93 regimens on the NCCN guidelines, then I think you have to ask yourself, why are we rushing so much to get the melflufens of the world on the market? Okay, so that's one point. I think as a general rule, if we run more randomized controlled trials in the last line, we will establish something very quick, which is, without taking any more time, does this medical product have a survival benefit among people who receive the current prevailing best available standard of care? I think subsequent randomized controlled trials need to test a different question. They need to test, should everyone get it earlier up front? But that question can only be tested when you're saving it for later in the control arm. You have to give control arm patients access to that drug as subsequent studies. I think we cannot justify treating people who don't feel pain, who don't feel their cancer, until we prove they live longer or live better. I think we can't medicalize healthy people. And I think we should ban thought leaders from taking patient performance. Okay, all right. Well, all right, I'm going to skip this MRD stuff until the end, and we're going to turn it over. Now that I've killed enough time, Aaron's up. All right.
Want me to wear this?
Just pin it on your lapel. Yes, we have about 20 minutes left of an unlimited open bar, followed by a cash bar. And so it's very important. The most important endpoint is the time until you get your next drink. That should be in the next 15 minutes. So go ahead.
Yeah, you're going to need some alcohol when we go over the CAR-T and smoldering. So this is supposed to be interactive. So we're going to go over a few of the abstracts. Right, it is myeloma heavy. I apologize. So the first study we'll go over is Daratumumab monotherapy versus surveillance in smoldering myeloma. So right, smoldering myeloma, it's a precursor condition with varying degrees of progression to active myeloma. Unfortunately, I think also as Manni's pointed out, there's many definitions for high-risk smoldering myeloma, but commonly used things are amount of plasma cells, the amount of M spike, the free light chain ratio, et cetera. So this study took high-risk patients with smoldering myeloma, and the high-risk criteria included a bone marrow plasma cell percentage over 10%, and you have to have an M spike greater than 3 grams per deciliter, or an IgA, which I thought was kind of odd, or immunoparesis, which means that your immunoglobulins, 2 of the 3 are low compared to the others. So that's who was included. And so they took these patients that walked into some medical center, got a lab drawn that was abnormal and a workup that resulted in smoldering myeloma. They randomized them to 3 years of Daratumumab.
Sorry, I know I'm holding.
I don't even know how to use this.
Just click to the right.
Yeah, so it randomized them to 3 years of Daratumumab versus observation. And the endpoint was progression to myeloma. So as Vinay pointed out, right, when we think of myeloma, we think of broken bones, hypercalcemia, end organ damage. But the progression in this study actually included SLIM criteria. So that's the free light chain ratio greater than 100, or more than one really tiny thing on an MRI. So it actually included really asymptomatic progressions, right? Progressing from smoldering myeloma to slim myeloma is still an asymptomatic progression, okay? And what it showed was that the PFS was better, okay? So not a surprise, right? We're giving active therapy and it delayed progression. There was no difference in overall survival, okay? Now, the study, when's the study being presented? Who knows?
Monday.
Yeah, so I'm unaware. So first, is this a good study? So first, what's the question being asked? The question being asked is, are we delaying progression to myeloma? Well, it appears so, but what percentage of those patients are we delaying that it's just slim myeloma? What are these? I mean, what I want to know is if I'm giving therapy indefinitely, or at least 3 years, to someone who's healthy, am I delaying end organ damage, broken bones, irreversible renal failure, hypercalcemia that results in a hospitalization, severe morbidity? Or am I just delaying a bunch of slim crab or asymptomatic bone lesions on MRI or PET scans? And I'm very curious to see what the data shows when they present that. I doubt they will get that granular. With the prior studies in smoldering myeloma with Revlimid, I've repeatedly asked the investigators for the morbid progressions, and they did not collect that information. And without improving all, so this does not change my practice. What I also want to know is what post-protocol therapy. So now Daratumumab is the standard of care in newly diagnosed myeloma. So hopefully the majority of these patients are receiving Daratumumab when they actually progress to symptomatic myeloma, recognizing this study was probably done over a few years where maybe not everyone was getting that front line. So does this change my standard of care? No, although I believe they're submitting it right to the FDA for approval. I think this will sadly get approved, and why? I mean, this is better than Revlimid in my opinion. I mean, Revlimid's got all its issues. Daratumumab, it goes down like a nice beer, unlike a Revlimid.
It's better. It's better than a drug that causes teratogenic REMS drug.
It's not promoting TP53 acute leukemia, but it's expensive. It's medicalizing a bunch of patients. I think this will probably be widely adapted in the community. It's easy to give. It's easy to give Daratumumab. But I'm open. I mean, do people disagree? I mean, is this going to change people's practice in myeloma?
Who dares? No, just kidding.
My big question is what, because I always ask this to the presenters. I asked last year on this phase 2 version of the study. It's like how do they find progression in smoldering? Because some of them use IMWG criteria for progression, like we do in myeloma, where the rising legends and that's it.
This uses slim criteria.
So they're calling it progression.
Yeah, it uses slim criteria.
Active myeloma or slim
Stupid.
myeloma.
Yeah, that's stupid.
And there's 2 parts to it. First, you progress to slim criteria, which they have a PFS. I hear they have a trend to PFS2, which is then your PET positive bone. But whether you have a symptomatic bone lesion, that's completely, who's having dialysis, who's having symptomatic bone disease, who's having anemia that requires transfusion. The clinical entity is so far off the horizon, we have no clue.
Yeah, again, though, there's a good chance this will be approved and widely used. And again, once this becomes the standard, as we've pointed out in prior editorials, now the standard is going to be Dara, and we'll forever never know the actual true answer.
The only people who won't get Dara and smoldering are people in the next controlled study. That's the only people who are not going to get it. The rest everyone going to get it.
But the problem with this, this is a ton of Dara. It's 3 years of Dara.
Yeah.
It's a ton of Dara.
It's not. Janssen says they need 3 more. Well, I don't know.
They want it forever. At least it's not forever, but it's 3 years. That's a ton.
They say Dara is the Rituxan of myeloma, early and often. That's what they say.
Don't treat follicular lymphoma that's asymptomatic.
Yes, we do. We do in the new SWOG study. In the SWOG study, in mosunetuzumab vedotin.
No, this is a point we always bring up, and I think that just shows how I someone who treats all hematologic malignancies, so I approach it from kind of a generalist. But if you look across the various indolent, I think it's okay. Myeloma is indolent, right? There are some aggressive, but it's an indolent malignancy with a pre-symptomatic phase. In every other indolent malignancy where we've intervened early with novel, new, safer, better drugs, we have never, to my knowledge, shown an overall survival advantage. And when you read the recent CLL, was it the CLL 12? I forget the number.
I think 14.
One of them. They just published in JCO.
It's like ibrutinib versus observation in CLL you don't need to treat. And they say that even though there's a PFS benefit, without OS or quality of life, we shouldn't do this.
Yeah.
The CLL investigators have a different standard.
Yeah, the conclusion of the ibrutinib, which did the exact same thing this study did, right? It delayed time to progression to needing treatment. The conclusion of the CLL investigators was our standard of care doesn't change. If you read the conclusion of this study, where is it? What are they saying?
Dara monotherapy is well tolerated.
This strongly benefit of early intervention with Dara versus active monitoring, the current standard of care. So they're suggesting that this is the way it should be.
You know, I just want to add one thing. If the current standard of care is active monitoring, why did they cross over the SWOG study of Len? You know, like there's a lot of contradictions in the logic. If you really think active monitoring study, you shouldn't have crossed those people over. They could have been actively monitored.
One more question.
Yeah.
How are they defining high? Like, so they said one of the criteria. So you have to have less than 10% and then one of these?
No, you'd have more than 10% bone marrow plasma cells and either an M spike greater than 3 grams per deciliter, an IgA, or an IgA, which, who does
It's a non-IgG.
Is that standard?
2020.
Yeah.
That's what I.
Yeah, what I'm trying to say is a lot of these patients probably are in that high risk. Like they're going to go a long time without progressing.
I think they should put like drug shortages. I think this is contributing more to drug shortages. Actually, I have patients on myeloma, they can't get there.
Really?
Yeah.
Usually that's the cheap drugs you get a shortage of. You don't get a shortage of these branded drugs. I've never seen a nivolumab shortage. I usually see it's like cyclophosphamide shortage and like cisplatin shortage. No, but you really had DARA shortages?
No, it's just like payment.
Oh, yeah.
BCMA versus DARA, and they try to push for these. First line.
I see. Isotoxumab. I see. It's probably because the company's contracted a negotiated rate for ISA. Yeah, okay. So, you know, by Aaron admitting that he takes care of all malignancies, he's also telling you he's not a real expert.
No.
Because a real expert would know that this is good. Okay. Okay, next.
Next one. Yeah, we got to say it. So the next one. So let's, lymphoma. I like lymphoma. Okay. So this is a mantle cell lymphoma. It was just presented today, I believe. So who should we, so mantle cell lymphoma, it's one of those like intermediate lymphomas. Sometimes it's aggressive, sometimes it's not so bad. So this is a study looking at patients with mantle cell lymphoma in need of treatment. You can actually observe some mantle cell lymphoma patients. And these were older patients who weren't considered eligible for intensive like high-dose Ara-C-based regimens. So I want to ask before we get into this study, how are people treating in their clinic, you know, a 65-year-old guy with symptomatic mantle cell lymphoma who needs treatment? What are we doing? Who's given R-CHOP? Is anyone?
Dose-adjusted R-EPOC. Any takers?
Only if double hit. Okay. So, and who's giving BTK inhibitors? This is non-TP53 mutated. Okay.
Yeah.
So, and who's giving BR? Yeah, I'm a BR fan. So, this study, the ENRICH study, took patients with over the age of 60, and they randomized them to ibrutinib, rituximab, versus R-chemo. The R-chemo choices were BR and R-CHOP, okay? And the primary endpoint was PFS. Now, both groups got maintenance rituximab, which is appropriate. The ibrutinib rituximab arm continued ibrutinib till progression, okay? So, before we get into a little bit more into the weeds of this study, if you have a patient on BR, on rituximab maintenance, who progresses, what is the next treatment you are going to give such patient? The standard would be a BTK inhibitor, okay? So meaning, if you get BR, you're gonna get a BTK inhibitor. In this study, that one arm got BTK inhibitor R, and then BTK forever, okay?
So I think, yeah, that's something to be pointed out.
Important point.
How do you compare a fixed course where you get a treatment holiday, at least, you know, versus indefinite treatment? You know, that to me, I mean, not a treatment holiday, I get a little maintenance, but like, you can presumably get through your therapy. I looked at him because he did the meta-analysis on maintenance in this setting, didn't you? And you showed a survival benefit. You were the first to show survival benefit in maintenance. Yeah, I thought so. Okay, so yeah, so like, how are you going to compare those two?
And keep in mind the BR group where you stop therapy other than the R maintenance, you're going to get that BTK inhibitor the second you actually need it when you have symptomatic progression, okay? So the primary endpoint was PFS. It showed a PFS advantage of ibrutinib versus ibrutinib rituximab versus BR. But then they actually looked, and I'll have Vinay talk about this a little bit, uses some fancy statistics, but they looked at the subgroups of R-CHOP and BR, and the benefit was mainly all in the R-CHOP group, meaning ibrutinib rituximab was better than R-CHOP, a regimen no one uses, but then when they carried it to BR, there was actually a null difference. Keep in mind, including the fact that the ibrutinib rituximab arm got indefinite ibrutinib.
Yeah, so I think, like, before, when we were putting these slides together this morning, we hadn't seen any of the Kaplan-Meier. We just had this. And I read this thing that says there's a significant interaction, extremely significant interaction coefficient between the choice of chemotherapy and treatment effect. It says in the R-CHOP group, hazard ratio is 0.37, meaning IR kicked the shit out of R-CHOP.
Yeah.
0.37, really significant. But in the subgroup analysis of BR, now here they use subgroup analysis to denigrate this, but actually with an interaction coefficient this significant, it's actually a pretty decent analysis. In the BR group, the hazard ratio is 0.91, and it's non-significant. And what I told him it meant is, ibrutinib did not beat BR. It didn't beat it. And then as we were talking about it, next slide. Is it the next slide or 2 slides from now? Go to the next one more. As we're talking about it, oh, of course, you all know BR is better than R-CHOP from Matthias Rummel from 15 years ago. Next slide. Eddie Cliff posted on Twitter that this is what the curves look
they were
like.
presenting it, and those are the curves. And the other thing that we know from someone who was at the presentation, right? So we also wanted, so the overall survival wasn't different, okay? But even if it was, let's say the overall survival advantage benefited the ibrutinib arm, we want to make sure that everyone getting BR gets their BTK inhibitor progression, right? Because that's what we do in the clinic. They did not report post-protocol therapy in this study. But even assuming that if everyone in the BR group got ibrutinib post-protocol, it still was no survival advantage. So right now, my practice, although they're calling this practice changing, right, no one, I think, really is giving R-CHOP up front, at least I'm not, and BR seems equivalent. So I think what it does say is, okay, you could do a chemo-free regimen and be on a definite ibrutinib or fixed duration bendamustine. So I think it adds to a discussion with the patient. I don't think I'm going to widely adapt this. Also, right, no one's really using ibrutinib anymore, although with other BTK inhibitor studies in this space, I think we're making the conclusions that you can probably swap out with acalabrutinib and zanubrutinib.
Yeah, IR is more expensive, and it tickles my heart a little bit. You know,
Yeah, there was a 6%, 1 in 20 got AFib on the study.
Yeah, there's always AFib. I mean, at least acalabrutinib and zanubrutinib have AFib, as much. Yeah.
I mean, has anyone's practice changed by this? No. Okay.
Good.
On to the next.
We've a selection bias of the audience. Not since a health tree survey have I seen this kind of selection. We're going to talk about it. I've seen this kind of selection bias.
I should have Manni do this one. This is
Manni.
You want to come up here, Manni?
Come up here, Manni.
So I thought this was very interesting. So Daratumumab, as you all know, is a GPRC5D.
You have to talk into the mic.
He's YouTubing it for his fans, so.
No, for posterity. No, talking to this phone or into his microphone. This is not going to record.
All right, so Daratumumab is a GPRC5D targeting bispecific. It is obviously an effective drug. This was not Selinexor, but it's very toxic. It's toxic in the sense that the GPRC5D receptor is expressed on the skin, the mouth, and the nails. So what is interesting is this drug has now been out for a while, and we don't have any PRO data from the actual trial, and I haven't seen it yet. So instead of getting the actual PRO data from the trial, what we see is the study through Health3, where they took these 12 people, they selected
12 people, okay.
Yeah, so they selected them through the Health3 platform, and then they flew them to Chicago on, obviously, the pharma's budget.
This is how you collect
Yes.
quality of life.
And then
You pick 12 people.
Flew to Chicago. I'm sure that was it a Motel 6 you think they chose? Yeah.
exactly. So after you fly them and you wine and dine them, and they haven't died from the toxicity yet, like you've selected them, and then you ask them how the Daratumumab was, and then they're like, yeah, it was manageable. So it was just very interesting, the selection bias going on here, and this study received a lot of positive attention on Twitter, and I'm like, what am I missing?
Well, who's given Talquetamab here? Is anyone?
Although all
Yeah.
interviewees reported taste symptoms, 5 said their symptoms fully improved and 4 experienced partial recovery. 10 lost weight but maintained with adequate nutrition. Patients and physicians think of coping strategies like dietary modifications, using strong flavors like cinnamon, monitoring weight, prioritizing calories, using mouthwashes, lozenges, drinking water while eating, taking small bites. You can't take a full bite. And eat that cinnamon. Eat that fucking cinnamon and consume foods that are easy to swallow. What the?
Nah.
When you have to bring out cinnamon, you fucked up your mouth.
Yeah. As I said, I'm not going to listen. Talquetamab is a very active drug, and in patients with highly refractory myeloma, I think it's a beneficial drug.
But how many months do they actually need?
Well, yeah, again, this is now getting the case. Yeah. Anyone who's given the drug, it's one of the few drugs I've given where patients have said, let me have my cancer back. No, I'm being serious, and I'm not, these are people say that it has horrific side effects.
Selinexor, they say, I wish I were dead.
Yeah.
And Talquetamab, they say, enough is enough.
Yeah, and it's a drug that will have its place, but it pains me that I see this being moved up to frontline settings when we have much better. And smoldering. I mean, don't even. Again, I need another beer if we're going to talk about that. But it pains me. Yeah. 3 minutes.
It's only get, do you mind grabbing air and
Yeah.
He doesn't need another beer.
You know, I normally don't get nervous for these talks. My wife's here, and now I'm like, hey, can you grab me a bag? But so that's talquetamab. So let's move on to the next one. Do we have anything more to say about this, or?
I think, yeah. I mean, I think I use it. I think it's a life-saving drug, right? We'll see. There's no randomized data to date. Is there any randomized any GPRC5D? No. I spread it out a little bit. I spread it out in patients, and they do okay. It's still very toxic.
It's very.
So you alternate talquetamab cinnamon, or do you? Cinnamon challenge. Cinnamon challenge.
No, I mean, really, the appropriate studies would be if they would be giving less of this. Like I said, anecdotally, I've had patients who've had 2 doses and had remissions at over a year, literally. So I think that's where the studies need to go. But the studies that we're seeing being developed with talquetamab are giving it to healthy people with smoldering. Okay, so that's where we're living. This is this is another one for you, Manni. This was your choice. You got to come back up. So
You guys are gonna get this
yeah.
So
It's too late.
You're already canceled, man.
all right. So I mean, there's lots of authors on this study. We can see. So basically, they're looking.
They all worked hard.
So they're looking at teclistamab and whether previous BCMA therapy, how that interferes with the efficacy of teclistamab. Now, I mean for this to be interactive, so I'm going to ask you all this question. What do you think is wrong with this statement? Is there like the next slide? Yes. So, what do you think is wrong with this statement, the last sentence here? Waiting more than 9 months between sequencing BCMA therapies may be associated with improved PFS. What is this bias called?
Yes.
Yes.
What's the name of that?
What's the name? So this is called immortal time bias, right? Like if you have to wait 9 months, right, your disease is indolent enough, and you have to have survived 9 months, for you to get the therapy later. So these kind of analyses are called immortal time bias, and it's a big flaw. And what's sad is there were so many authors, and nobody really pointed that out, right? So it's kind of tragic.
I think I agree with like what he said. I might call selection bias, but I agree. But I'd say that what I think the challenge with this is you take 100 people who get some BCMA-directed therapy, okay, and then the people who are old and frail and vulnerable and can't take anymore, like who get really depleted disease, they're not in this. So already there's selection bias, like to try teclistamab in someone who's gotten cilta-cel, you're already, especially with insurance might deny you and all these things, you're already picking like richer people, people who have better disease, and then they go even further, as he says, and say, and you know what, and actually the person who didn't die in 9 months, and he got it, he did better than the person who progressed right away with rip-roaring disease. Well, duh, of course, it's so obvious. And to me, this is literally, there is a question, which is once you get one BCMA drug, how many more BCMA drugs do you need or benefit you? And that question can never be answered by these kinds of things. These things are just closer to propaganda to encourage these, To me, my guess is if I were to put a nickel on a bet, my bet would be that more than one BCMA-directed therapy only improves outcomes in the rarest subgroup of people who get alternated with some other therapy again like years later. That's my guess.
Yeah, or the patients who had from BCMA therapy number 1 who just had to stop because of toxicity, maybe not efficacy.
Like idiosyncratic toxicity.
Yes.
So true to one product, but not the other product.
Yeah. I mean, right now I believe, correct me if I'm wrong, myeloma experts in the audience, but the field is saying give BCMA 1 and then give that target a break and do some talc so they lose a little weight before you get on to the next target. So.
Does anyone I agree with a lot of myeloma people. What do you think, Raj? You agree?
Yeah, I mean, a lot of the real world studies in cilta-cel as well, they make this conclusion, which I think is wrong, that the time between trial and cilta-cel, that kind of correlates with PFS.
Yeah.
I agree. The only thing I would say is that if I know that I'm giving somebody cilta-cel, I would probably not want to give teclistamab right before that. I don't know whether there's no randomized trial to show that, but I would not want to use.
You don't want to bridge them with tech when you're going to give them
No, I won't bridge them with talc. I would probably bridge them with something else.
I mean, teclistamab. You wouldn't use teclistamab to bridge them.
Yes.
Because you don't want to flog down BCMA before you try to kill them.
Before I give them.
Got it. Okay. That's a biologic. I think that's very fair. I mean, I think that honestly, my guess is if we really did a lot of randomized studies, then teclistamab will win because it's just right off the shelf. And I'm not sure we're going to get much more from. Besides Parkinsonism, I'm not sure we're going to get much more from.
That's cilta-cel. Yeah, cilta-cel, excuse me. Okay, so everyone hopefully has their beer. So I've told this story before. I like using it in clinic if you never get the chance to rotate in clinic with me. Here's some 50-year-old person, male, female. You go to your PCP, and you get your routine labs, okay, which you don't really need probably. And the routine labs are drawn, and you're a pretty into patient. You got a little bit more money the most. You're well educated. Your total protein's elevated, and your PCP is doing good due diligence. He's like, you got a total protein that's elevated, and I'm going to work it up. So they get that SPEP, got an M spike. It's the tie. They have an elevated light chain, and the patient feels fine. The rest of the labs are normal, and he's like, you know what? I think I found something. I did something good for you. I'm going to refer you to Dana-Farber, okay? And so this patient...
That's the best.
Yeah, the best. They're well off. They're doing well. And they're on their way to Dana-Farber.
Their Western blots are never
They're on their way to Dana-Farber, and they have their appointment in the myeloma. I think they have the Dana-Farber is so big they have a pre-myeloma division, I think.
You need a pre-myeloma division for your pre-donation.
Yes. And you sit there and you know what? I go, I think you might have something. I'm going to get a PET scan, a bone marrow biopsy, order all these fancy things. And everything comes back that you have smoldering myeloma, which we talked about earlier, is a pre-cancer that is asymptomatic with varying degrees of progression to active myeloma. And the team in front of you says, you know what? It's your lucky day. I know you were healthy and you got here to me, but it's your lucky day. We got a study for you. And studies are always the answer, if you look at the NCCN.
The best option is clinical trial.
Yeah. And not only is this a study, this is a study using scientific, like sci-fi futuristic stuff. We're going to take your own healthy immune cells and engineer them to kill this lab abnormality in your blood.
Would you like to join
Yeah.
our prism?
Of course I want to join. No, honestly, we're joking, but this is the truth, right? I mean, this is really, and so they're like, fuck yeah, let's get that. We don't want you to break your hip or your bones or get ill. So they sign that thing. I'm sure they get their great consent, and they're enrolled. And this study basically is this, and I'm going to report the results of this experiment. So this was cilta-cel for smoldering, and they took patients, and correct me if I'm wrong, Manni or some of the audience, they took high-risk smolderers by the 2220 criteria,
yes, 2020, yes.
Which is an M spike. It's easy to remember. M spike greater than 2, plasma cells greater than 20%, or light chain ratio greater than 20. And you only need 2 to be high risk. And if you look across varying data sets, it's not really that great at predicting high risk. You could also have an IMWG score greater than 9 and a high risk pathema. So a varying group of patients with varying degrees of progression to myeloma. And their endpoint. What would be the endpoint of such study? Safety. I can give cilta-cel to relapse refractory myeloma. Let's see how it does it in healthy people and measure safety. They enrolled 6 patients, and they got results, and an oral abstract at ASH, by the way. And so here are the results of this study in this poor individual who went to their PCP and got routine labs. So
even Barlogie was like, damn, that's a lot, man.
Yeah.
A lot.
So
even Barlogie.
Grade 3 to 4 hematologic toxicity was in 100% of individuals. Grade 3 non-heme, there were 20% grade 3 to 4 hepatitis. 100% of patients got cytokine release syndrome, so that is a in-hospital thing where you have fevers. But don't worry, only 1 in 3 got grade 2. Oh, it's only grade 2. That's like needing an ICU with blood, you get a lot of fluids, right? Okay. So that was the rates of CRS. 4 of those patients needed tocilizumab, another expensive immunomodulator. 2 of those patients, 33, got dexamethasone. Other toxicities, someone had Bell's palsy, which doesn't sound bad, but I've given this drug before. I have a patient who's 3 months out who still can't really swallow or see straight from cilta-cel. Now, this was someone who would otherwise be dead from his myeloma, so risk-benefit here, but still quite a serious toxicity. There was also a grade 4 ITP, which needed IVIG, Dex, and a lot of N-plate forever. And this is what the study did and is being presented at ASH. So I'll be honest, I think this is a sad for our field that we're seeing. First of all, the study doesn't answer anything meaningful. Are we curing these patients? I have no idea. Are we helping these patients? Well, no one on earth can say we've helped these patients in this study. But I honestly am open. Clearly, there is an interest for this in the field and in the field of hematology. It's an oral abstract. This audience is skewed, but what am I missing? What is the purpose of such studies? Yeah.
Yes, active drugs earlier. When I saw these results, I said, that's the last time I complain about neuropathy to an intern. You know,
No, I think
what happened to me? But I think this product also has in the latest Janssen release, there's a 3% risk of drug-induced Parkinsonism, and there's a 2.7% risk of secondary malignancy in randomized data. So this is an extremely dangerous product to let, honestly, in my opinion, healthy neurotic people take. Because to be in this study, not only you're healthy, you feel fine, but you're likely neurotic. Because, I mean, I don't say that it's a bad thing. Like, it's okay to be neurotic, but the role of the doctor is to shield a neurotic person from participating in a lethal, unproven therapy for something they don't see or feel. And the other point I want to make is a non-randomized study in smoldering just simply has no value. Like, I cannot think of anything useful that could ever be answered in a non-randomized smoldering study. If you randomize, you have to measure the two things that matter, and the control arm has to get treatment when they actually have myeloma, which is going to be years in the future. Yes, Raj?
I have a question about the non-randomized part.
Yes.
Which, I would love to hear what you guys think. So, people who are the promoters of these kind of studies with Teclistamab or CAR-T in smoldering myeloma, they say that if you take, let's say, 20 high smoldering myeloma patients and give CAR-T, and in 10 years the PFS curve is flat, like not a single one has relapsed, then you would prove that it can cure those patients. So do you buy that argument, and what do you say to that?
Okay, so I would say that, like, you know, if you give a dostarlimab to stage 2 rectal, you saw this 100% CR rate with 12. But that's a bulky, measurable disease you can see. I would say that we really don't know the natural history of the 12 people that are eligible for this study. Like, in other words, what's the counterfactual? I'm 100% persuaded that active myeloma drugs can extinguish myeloma clones, and there'll be some fraction of people take a long time before they grow back. I'm not persuaded that drugs that cannot eradicate the last cell can somehow magically eradicate the last cell when every piece of available data has suggested that nothing we've given in earlier has ever cured anyone that, when it, you know, it doesn't cure it late in the myeloma space. And I guess I'd say that with 10 people or 20 people who are the kind of elite people in this study, I don't think it'll prove anything. Like, you'll still need... That's what I think. 60-70% would never have needed any treatment. And then, you know, and I still don't know about, like, you know, are they actually, is their life better off as a result of having done
Well,
it?
you cured them, but they have AML now.
And that's another point.
No, it is true.
Even 1 or 2 second malignancies or Parkinson's disease could blow up the whole, you know. And also, like, you know, when we're talking about, like, in the Janssen study, we're talking about how many cases of Parkinsonism was? There's 8 or something. It was like 8 cases out of like a couple hundred people. Like, with 12, you know, you do have no power to detect safety signal with this kind of thing. And in fact, you could even have a drug, like, like people will die a lot. Like, you can have a drug that kills people, hastens death, and you'll never find it in this study. You could follow them 20 years and say, oh, they died of a car, you know, he died of other things. But it could have hastened death, you don't know. I think it's a very... To me, we've written so many times, like, IRB should cancel this study.
I mean, if IRBs are allowing this kind of stuff, yeah, I don't know what their purpose is. It's supposed to protect patients. So.
Their goal is to make it difficult to do retrospective chart review and easy to do shitty randomized studies. That's all I see them doing, you know?
Yeah, I think, though, this study taught us something valuable to maybe not go to your PCP for the annual checkup.
I guess, like, it's, to me, the other problem is that, like, the field celebrates this so much. Like, why is this this is like, I don't know. To me, it's like, I don't know.
I don't know, we joke around. I mean, this study to me is pretty sad.
It's pretty bad. It's
on
really,
our field. Okay, anyone else have final comments on this, or are we?
Yes.
What's the timeline of enrollment? Because if they see any side effect, they should have stopped the study.
I guess that I think that they're going to say there's no side effect that will stop the study because we know these are side effects of the product. Yeah. What are you going to say?
I just had a question. So I know, like, it's bad, obviously, to encourage kind of studies for patients, like, empowering people. But do you think it's, like, good that's a real abstract to show, like, how shady this could be for patients?
But this is promoting people like us to do this kind of stuff because they're being an oral abstract at ASH is a big deal. There's going to be a packed audience that's being written up. And I doubt, I'm not going to beat the oral presentation, but I can't imagine that the panel up on the stage, I don't think they invited Dr. Prasad to sit on that panel, or Manni or Raj. No, I mean, they don't.
Some of the worst studies have been, like, let's talk, like, Boston, Lancet, solid tumor ones, Vision, New England Journal, you know, you guys don't care about solid tumor. But, like, Agile, where was Agile published? New England Journal. Yeah. So I guess one point I want to make is that, like, as long as we live in a world where really fundamentally flawed studies gain all the accolades, I think you can't, it's going to be really tough. We're incentivizing, as Manni says, if I were an investigator working at a university and I want my first big break, the easiest thing to do is to go to Janssen and say, hey, listen, why don't we try Dara in high-risk MGUS by...
they're doing that at Harvard also.
Yeah, I know they're doing it. Dara in high-risk MGUS. Or why don't we try whatever new costly drug... a small company will be happy to fund your preclinical early disease because they're desperate to gain any market share they can, like a Karyopharm. I think it's problematic.
Anytime a new drug is approved in myeloma, there is soon, if not already, a single-arm study at some center that's an IIT using said drug in smoldering myeloma. Prove me wrong, but go Google it. It's even in Selinexor. Yeah.
And I think it's dangerous. This is online, so patient will read it and come to the doctor. I have smoldering, can I do
Yeah, give me
and,
some.
and also, like, that selects for a certain type of person. Like, we all know, in myeloma, there's a range of people with the disease. There are a lot of poor people and vulnerable people who have the disease. None of them are in any of these studies, and in the surveys we're going to talk about in a second. And then there's a lot of, like, wealthy people with the disease, and there's a lot of overdiagnosis of the disease, and they are the ones that are disproportionately enrolling in these studies, and their biology is different to to the point of, like, we don't know what to compare them against. I think it's very tricky.
Okay. So we've beaten that one down?
Okay, yeah. Well, that was the most...
Yeah, we're starting to run out of time. We'll go. What's
No, we still have 45 minutes.
Oh, we have 45 minutes.
I was going to tell you to go slower.
Oh, God. I'm a fast talker. Well, I think the next one is, we could spend a while on this one.
Probably. So, but before we start, we want to know something about your dietary pattern.
Yeah, I want to hear.
No. We don't taint them first. Let's ask them. First, number one here. Is there anyone here who is vegan?
We're our vegans.
Is there anyone?
He's gonna live a long time. Not gonna. Yeah.
He's maybe a Seventh-day Adventist living. Okay, who is a ketogenic diet like Aaron? Ketogenic.
Well, the beer is.
Huh? Well, and by the way, I think he's doing better now, so he needs another one. But oh no. Okay. And who here is sort of eats everything omnivore person? Okay, and who here is like vegetarian, not vegan, vegetarian? Okay, we got some. Okay, so we have a range of dietary.
Who has patients that ask about diet with cancer?
Yes, everyone.
And would you say that that's pretty important to them? And why do you think that? They can control it. It's very, and I get these questions, I'll tell them all these things and they're like, but what about, can I eat my steak? Can I do this? It's what they want to know.
He just steers them to green tea, Just steer them to green tea and you're good,
Okay, so hopefully I do justice to this study and tell Manni or someone fill me in if
you have to do it. I don't think you
Why
have to
can't
do
you
it.
do it? So
I think you are the only one to do it neutrally, so.
So this study, so I guess there's some preclinical stuff that's been looking at plant-based diets, a lot of lettuce, spinach, high fiber, all the good stuff, at decreasing the risk of MGUS progression to active myeloma. So this was a study done that was the Nutrivention study that was single arm, and this used this high fiber based diet. I think at the oral abstract they'll probably define like how much fiber is high fiber, like is it 4 spinaches a day, but they'll define that. And what they did was they looked at patients, so it was 12 weeks of health coaching to get them in the mood. For someone like me, I'm not really thrilled to start this, but also you have to imagine, I suspect the people enrolling on this study were already kind of gung-ho on this type of diet, so it would take a lot to convince me to give up meat and the stuff I like. And what they did was 12 weeks of health coaching, and they took these 20 patients with MGUS and smoldering myeloma who had a BMI greater than 25. And the primary endpoint, again, was just feasibility. So the primary endpoint in this oral abstract was, can we give people with an asymptomatic...
For you, it's not even feasible either time. You need a feasibility study, Aaron. Come on.
You're right, actually. I'm saying, this it is. Can you convince people to do this? So feasibility and adherence, and they wanted to look at the BMI reduction.
Can you convince people who sign up to do it?
Yes.
Yeah.
Yes. Can you convince people who sign up to do it? And then secondary endpoints were quality of life. Well, mine will go to shit, but metabolic markers.
Literally, he'll be in the toilet all day.
And then, then they do the microbiome, and we all love our microbiome, where you can look at all the different types of bacteria that change with the course of a treatment.
There's not a day I don't wake up and I say, I want a more diverse microbiome. Yeah. I say that every morning, Aaron, every morning.
And they did even more. They did immune profiling, did all these fancy tests, and they even did bone marrow biopsies on these poor individuals. Okay, so... But they got skinnier, so the biopsy got easier. And then to further, it's one thing having actual data in humans, but they did this to poor freaking mice also. So they took some mice with a myeloma or
you can't jump to a human with a high fiber diet.
Yeah, so they also did in a mouse. A same type of diet in transgenic mice, and I'm no mice expert, but these are like pre-myeloma mice, okay? and they were monitored for progression. Okay, so the first thing that they did show was that this high fiber diet was safe, so that's good. It was feasible, and it did improve the quality of life. Now let's get back to, right, these were people who signed up for this, who are, right, as much as I make fun of kind of the dietary literature, there is some, it's placebo in my opinion, but when patients have control over something, it truly gives them, they feel empowered and they do feel better, and I'm not dismissing that, okay? Right, I mean, this is an important thing.
I'm actually going to defend this study. Because I think he's too mean, and these guys are going to be too mean on it. I'm going to defend this. So here's how I'll defend it. I would say my defense of it is, in a world where everyone wants to give CAR-T in your sleep and dare in your sleep, at least this is cheap. At least it's cheap.
And it's safe for the most part.
That's the second thing. And I'd say, I'd say that, like, I don't think it's harmful. I certainly don't think this is harmful. No one's getting plant-based diet-induced Parkinsonism from this. Okay? I also want to say that the people who sign up to do it, they want something, desperately, craving something. I bet if you randomize them to 4 arms, and in 3 arms you say eat meat only, eat this only, eat that only, all those 3 arms will be happy, and the only arm unhappy will the arm you say, I don't know what to do. I think so. I suspect they'll be happier. But do I actually think it'll slow the biology of myeloma? No, I don't think so. Yeah. I mean, I guess I just think that that's incredibly doubtful. And, Manni made a point, which is like in the U.S., the types of people who tend to adopt these diets are a certain socioeconomic class and a certain religious, and they have other sort of migratory things like the Seventh-day Adventists and these sorts of people. If you did the same study in India, you might get the opposite because meat is a sign of wealth and affluence in places where you don't have access to meat. So you might get sort of the opposite epidemiologic data. But I guess my defense of it is let's
show what it showed. So it improved a bunch of surrogates, right? It improved insulin resistance, adiponectin-leptin ratio. I didn't know that was a thing, but it improved that. And their microbiome had this increased alpha diversity in butyrate producers. Manni, can you educate everyone on this stool butyrate? Am I not allowed to call you Raj?
We already know that the stool butyrate levels are more favorable in people who eat more plants.
Yeah, so.
That's the knowledge from the general population. So why would that be any different in people with MS?
So,
of course, based butyrate levels will also get better if they eat more plants.
So, a ton of preclinical data showing that butyrate levels.
Yeah.
What was your last butyrate level, Eduardo?
I have no idea.
Wow.
So there's preclinical data with butyrate. Yeah.
I want minimal residual butyrate.
You're wrong. You want lots of butyrate.
Sorry, I want maximal butyrate. Yeah. Maximal butyrate.
There when they were doing the preclinical data for this, so I remember very clearly what they were talking about with this.
You were there.
I was there a little bit.
I see.
So I remember where they were talking about this, and I thought it was. But the main thing was the microbiome. That was like their
I don't even know what it means to look at microbiome diversity. They're only looking like how many firmicutes and what's the other one they got? What's the other one? Firmicute and something else. Those are like 2 major lineages I was looking at. Anyway.
Yeah, it showed that long-term progression trajectory was like reduced in 2 patients. I don't know how many of you have taken care of MGUS and smoldering patients. We see changes in these things all the time without any intervention. And I'm only pointing this study out because this was probably one that will make the news. This is a trendy kind of stuff. These are the ones that are flashy. And now, more importantly than the adiponectin-leptin ratio, how did the mice do? Okay. So they had an increased progression-free survival of 12 weeks in the control arm to 30 weeks. So that's promising. And they showed some bone marrow surrogate stuff. So, again, this stuff's going to continue to come up. But what's our pretest probability here? Manni's recently done an amazing review, dietary interventions in cancer. So I always tell my patients, is a specific diet going to shrink the cancer and make me live longer because of the diet? I think we all know without a rigorous study that eating healthy and being active are probably good things. I don't need to spend billions of dollars measuring butyrate in the stool of mice to prove this. But whether that specific diet is going to impact...
Only millions.
Yeah, millions, excuse me. But they've studied specific diets. The breast cancer literature is full of this, and they've all been negative, okay? So it's very unlikely that this is ever going to be of clinical value. I guess eventually there'll be a positive randomized study based on pure chance. But that's where we're at with this stuff.
I guess. I agree with everything he said, but I think that my honest opinion is in the whole scheme of all the things in oncology, at least it's cheap.
But here's why I take home. Now we have patients with MGUS that are MGUS. That's a nothing for most people who are going to some old farmer, his favorite thing in the world to do is eat a big steak, and then he reads this. You're going to have people change their habits potentially based off that.
Okay,
No,
I agree. I agree with you.
No,
yeah,
we're going to avoid certain things
I know.
when, like, the one thing
That's
that gave
harmful.
them quality.
There are arms of even non-intervention drugs, right? So these are people who may never have gotten a bone marrow biopsy. So you're going to get a bone marrow biopsy, and you're going to feed them the shit for a few months, and you're going to repeat another bone marrow biopsy. Like, all of that was unnecessary if they weren't on trial.
It's true. I hear that. But let's say you got to either send them to Dana-Farber or the plant diet. You have to choose. They're getting a CAR T or they got to eat some plant food. Which one do you choose? I mean, I got to say.
Well, I think the next study is high-fiber diet plus Cilta-Cel and smoldering. There you go. That's a free IIT for anyone.
All right. Let's go next one.
Next one. Okay, so this is the first. Okay, that's the conclusion.
Last slide, yeah.
Okay, eat some more fiber. Selinexor. And this is actually an important study, because I'm a critic of this drug, but as Vinay so Selinexor, everyone's favorite nuclear exporter inhibitor, right? So the mechanism it actually is a beautiful mechanism.
But what was the podcast you went on where you debated the CEO?
That was Shadi's. I did. He's no longer the CEO.
You need to listen to this podcast. It was the most brutal thing I've ever witnessed. I mean, not since the Tyson fight have I seen someone get beaten beaten so bad.
Now that when Shadi invited me on that podcast, I didn't know that guy was going to be there. He surprised me. But
really?
So Selinexor, I do actually like the mechanism, right? So tumor suppressors need to be in the nucleus of the cell to suppress the tumor from becoming a tumor.
He wakes up with nightmares saying the tumor suppressor is not in the nucleus of the cell. It should be the nucleus.
Drug, there are channels in the nucleus that pump out these suppressors in cancer, and then they become cancer. So this inhibits the pumping out of the tumor suppressors. That's the mechanism.
And the elephant has all the tumor suppressors in the nucleus.
Yes, they do.
There's 53 copies of p53.
So this Selinexor was approved based on the Boston study. And the Boston study, as Vinay pointed out, was Seli, Velcade-Dex versus Velcade-Dex. There were numerous issues with this study. First, no one used Velcade-Dex at the time of enrollment as a control arm. Number two, everyone on Earth who was in the control arm already got Velcade-Dex as part of their induction regimen, and it showed a modest improvement in lowering the protein for a few months. Right, that's what PFS is in myeloma. It got approved based off that. The drug is about $25,000 a month, and it is not an easy one to swallow. There's quite a bit of toxicity. They'll claim that we're dosing it wrong, but whatever. It's clearly a marginal drug. So, but it got approved.
But one thing they never suggested was taking with cinnamon.
Yeah.
They never went that far. They never went that far to cinnamon and peppermint.
But you know what? This is actually important data, because they took this marginal drug and now they did another randomized study.
In China.
In China, okay? And what they did was, it's basically this, right? It's the same study as Boston. It's in a Chinese population, but it's the Boston study. And I already told you all the issues with Boston and the marginal benefit. But now we have an additional data set with this drug.
Boston and Beijing.
Yeah, and what they showed was their endpoint was PFS. And this drug in the Chinese population, with all the problems of this study that are shared by Boston with a crappy control arm and all this stuff, it did not even show a progression-free survival benefit that was statistically significant. Okay, so Vinay, you think the FDA is going to
rescind the approval? You know, it actually raises the question that why would a study that was probably conducted predominantly in like Western Europe, South America, and North America have a PFS benefit with no OS benefit, and a study conducted predominantly in China not even have the PFS benefit? It's a really interesting question to explore. Things that leap in my mind might be that I don't know this to be true, but one of my thoughts would be I would look into. Like, are these patients so compliant that even if they have severe toxicity, they still follow up with scans, and there may be less informative censoring in this study than Boston? Because you can imagine...
Can you explain informed censoring for people like me who need a refresher?
Okay, so let's say we take like 200 people, we randomize them, they have cancer, we randomize them to one arm to sugar pill, okay? In the other arm, we don't give them an active cancer drug, but we give a very low dose of a poison. Let's say we give a low dose atropine. Okay? Oh, you gotta go. Okay.
So he's gonna put his studies next.
He's gotta hang up his poster.
For 5 more minutes. Your poster, you have a resident there.
Yeah, come on. Okay, so in one arm, we give him a low dose of something that's mildly toxic. Okay? You can imagine that at the first and second and third and fourth follow-up scans and visits to draw your blood, there's some people who get knocked out of this arm. who get that slightly toxic drug. They're not doing anything for their cancer, but they're not going to make it to the appointment because it's just toxic enough that it's like, I don't feel good enough to get there. Who are those people? Is that the average person in the study? No, it's probably the older, most vulnerable, frailest person. So it knocks those people out. And then the PFS you're measuring is only measured in the people who show up. It's not measured in the people who don't show up. We assume the people who don't show up are no healthier, wealthier, or wise than those who do show up, but that might not always be the case. We assume that the censoring is uninformative. It has nothing to do with the outcome. But if you censor people who are slightly more vulnerable, you will have informative censoring. It'll change the outcome. So my hypothesis would be Seli, a very toxic drug, knocks out the most vulnerable people in North America, South America, Europe, where people are less likely to comply. And in this study, for whatever reason, they pushed through this trial hard, and they made those people come back and get scans even if they had toxicity. That would be my speculation as to why the two have results differently. What do you think?
No.
You speculate that too.
There was censoring that happened quite a bit, and I think there was
Oh, it was full of censoring. It was knee-deep censoring on that.
Yeah, and in all honesty, I think the drug is pretty much, I mean, I wouldn't be surprised if they even, do you think they ever voluntarily, I mean, I don't know anyone who uses much of this drug.
Because the company is Karyopharm.
Yeah.
And my thought is that a company that has one product will never let it go. If it were Pfizer developing the same drug, Pfizer would have abandoned this pipeline a long time ago and said it's too toxic. But a one-hit wonder company cannot let go of this product. So I suspect they'll keep pushing.
Yeah, I think they're selling now the data that somehow Selinexor pre-CAR T improves the T cell fit. I'm being serious. This is what you'll see. It improves T cell fitness some magical way.
Oh yeah, there's a solid tumor. What was the solid tumor? Oh, it was uterine pancreas. No, it was
uterine.
I thought it was uterine.
It failed. Oh,
in the solid tumor trial, it worked better in P53 wild type,
Yeah.
and in the liquid tumor trial, it worked better in P53 mutant. So they have some story about why in solid tumors, you need to keep the tumor suppressors in the nucleus, and in the liquid tumors, you don't. They can flee the nucleus. I'm like, what though? It's quite a story.
And this is not a joke either. They even did a randomized study in COVID during peak COVID.
Yeah.
They gave, horrific COVID, they gave them some Seli.
You got bad COVID, you're on your knee, you're like really getting crushed from COVID, and then they come along and put a Seli in your mouth. I'm like, oh, they want to finish you off. They want to finish you off.
The study was negative. I'm still waiting for the publication.
I was too busy taking ivermectin, so I was okay. No, I wasn't. That didn't work.
Yes, you were. Be honest on that.
No, I never took it. I never took it.
Should we talk about RFK?
No, that's when the camera.
We need more time.
We could eat up time.
Okay, and then we'll finish with the last study.
Last one.
And we can.
Then we do Q&A.
We can do Q&A.
Yeah.
This is actually one of the. Granted, I'm biased. Do you want to talk about it? Or you want me to? Hopefully, I do justice to your.
This
study.
is a remarkably good one.
It is actually, and although it's, I was, kind of giving Manni a hard time. Oh, a survey study. That's scientific. But this is looking at what matters, what our patients think. Okay, not what we think. Okay, getting that MRD to 0. This is what patients think, and I'm going to butcher presenting this study. We have lots of stuff. So what this was a health tree Cure Hub study. So this is where patients who are part of this patient organization, correct? Okay. Yeah. So it is a selected group of patients who sign up for this. It's a patient advocacy group. Okay.
And you flew them to Chicago or no flying? No flying to Chicago in this study. Okay.
Yeah, and these were patients with active myeloma, and they were asked the following questions, and I'm going to read how they're written for patients. So question 1 was presented the choice, and you'll see where these are addressing the clinical studies, a 3-drug choice versus a 4-drug option for newly diagnosed myeloma. Both options provided patients with similar quality of life, 4-year overall survival, but the 4-year drug PFS was better, okay, with increased risk of infections and neutropenia. So it basically asked patients in standard language, do they agree with quad therapy up front? That was question 1. Question 2 was...
And he's masked the name of the drugs and the trial, but he has the same PFS. He's telling you the PFS, and he's put it in layman terms. So he's asking you, do you like Perseus? But you don't know it's Perseus, okay?
Okay.
Next one.
Next question was, assuming you have achieved a good response to induction therapy and are presented with a one-time treatment to deepen remission, a bone marrow transplant, okay? Although, right, you didn't say bone marrow transplant, okay? So they just said you get a one-time thingy that's going to deepen this remission, or continue induction treatment weekly for 4 additional months. The one-time treatment has a high likelihood of causing 3 months of decreased quality of life. That's what it does. Short-term side effects. This one-time treatment increased your progression-free survival from 65% to 81% with no increase in 5-year overall survival. So it again used words like this to explain the role of auto transplant to patients. But you didn't say PFS, did you? Or no?
Yeah, so we described the drug PFS as the Now that, if anything, biases towards the effect, because not all the effects are symptomatic, but you can simplify that, how you explain it.
Yeah.
And this is basically Paul Richardson's determination.
Yeah.
This is the result of determination, Perseus. He's asking, and we'll talk about who he's asking, but he's asking people, if anything, these are the people who will want these things.
These are the select
I think
group, yeah.
these are the wealthy people who will want these things, and he's asking them in a way that actually makes PFS sound better than it is. Because if you said M protein more than 25% for baseline, blah, 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 they're not going to be as interested in
Also,
it.
I'm going to steal this stuff. This is great for consenting patients, too, this kind of language, okay? And this is how we should be consenting our patients. Question, as opposed to like, oh, we'll make your MRD a little bit lower. That's great stuff, you know? So question 3 presented the choice of a 1 to 2 drug maintenance. The 2 drug maintenance option, again, increased progression-free survival by that percent, i.e. the Forte trial, right? That was KR.
I usually maintain people with venetoclax maintenance. Do you like that as a maintenance therapy?
Yeah.
Because I like that.
And again, with a similar overall survival, and they discussed the greater toxicity with the 2 drug maintenance regimen. So this is the Forte study. And then question 4 presented the option for multiply relapse disease. So this is taking kind of our end of the line patient who would be a candidate for Selinexor or melflufen or belantamab. And would you take this drug if it improved progression-free survival by 2 months, but had a lot of side effects or increased side effects with no overall survival? So let's see what our patients actually think when consented, in my opinion, appropriately. Okay, where are the results? So with quads versus not, 50% of patients said it's not a big deal, the quad versus triplet.
Do you believe that? To
That's
me is
actually I'm surprised by
that's
that
astonishing.
one. Yeah.
Like wealthy people in this network, and half say,
Yeah.
I don't want Dara VRD, I just want VRD.
When they're presented this way.
So half say.
As far as the consolidation was going to 50-50, okay? And this isn't even taking into the nuance of standard risk for high risk where you would even sway these things. So 50% were like, I don't want the auto. As far as the 1 drug, this one's my favorite, and I never use 2 drug maintenance. I think that's stupid. I disagree with Mayo. 84% would choose the 1 drug maintenance over the 2 drug maintenance. And then in the relapse setting, no one wanted Selinexor, 93%. Okay, that's not a shocker to me when explained appropriately. But this is pretty.
This is so good.
Pretty important data. I think it speaks a lot to what we think is doctor. Again, your very first point at the start of this discussion: what matters and what we think matters. And I think it's our job. I know we're making a bunch of jokes and being a little bit nasty, but it's really our job as physicians. We need to do better. We have to do better educating our patients, our colleagues, and the public. And and I think it's a monumental task, and I know we're trying, but I think that's what we all need to be doing. Because when you see these results, they're showing not really what this whole conference is about to present. Okay.
When I work in the VA and take care of double-hit lymphoma, okay, newly diagnosed double-hit DLBCL, in the VA in San Francisco, you can get dose-adjusted R-EPOCH for double-hit lymphoma, but you have to come all the way to SFVA and be hospitalized for 1 week to get it because we don't have pumps to send them home with. Or if you're from Crescent City or Eureka, you can get local R-CHOP once every 21 days. That's the choice. And every time I come on service, they're like, oh, the vets say they want dose-adjusted R-EPOCH, so we schedule for EPOCH. I said, how did you say that? You said, well, you have double-hit lymphoma, so you're supposed to get dose-adjusted R-EPOCH. I was like, that's not quite consent. Let me tell you how I consent to them. I go in, I say, listen, hey, I hear you live up north in Mendocino Valley, and you live 7 hours away, and we have 2 treatment options. We got this one option that they can do real near your house. It's a bunch of drugs they do 1 day in about 6 hours. You go home for 3 weeks, you stay at home, you'll be at your house, and we got this other option that requires you to come here, and every 3 weeks spend a week with us to get this infusional drug. And I'll be honest with you, most of the doctors who are experts in this field, they believe it's better to come here and get this treatment. But we don't have proof it's better. We don't know for sure it's better, but we believe it's better, okay?
And we know for sure it's more toxic.
We know for sure it's more toxic. We know for sure it's going to put a kink in your schedule.
And we have randomized studies in very similar disease showing absolutely no benefit.
So then I tell them about
Bartlett's
CALGB, and I say, we study this in everybody with the disease, not with your particular mutations that we think makes you higher risk, but in everybody with this kind of condition, and lo and behold, it didn't do anything better than the usual treatment. But we don't know if that applies to you. And people, most experts, I'm telling you, the experts think it's better. They just think it, but they don't know it for sure. So what do you want to do, like knowing it might be theoretically better, but you got to come here, and every time they say, man, I got a dog, I got a life, and honestly, even if it's 20% better, I ain't going to come down here. I didn't even know there was an option near me. And I don't care, 40%, but they don't care. And so I want to stay home. And so to me, that's informed consent. And those type of patients are not in this survey. Those patients are not being surveyed because there ain't no organization that surveys those people. And if you survey those people, the result will be even more stark than this. They'd say, to hell with your fourth drug, to hell with your, your double maintenance, and to hell with your transplant, I think.
Informed consent is truly the hardest part of our job and the most important part of our job. And it's something that's hard to teach, and it's way easier to just say this, improve some meaningless number by a little bit and tell your patient that. And though most patients are we're in a very privileged position, the patients will trust us for the most part. And it's our responsibility to kind of bring it down to earth to them, to explain them so they can make better decisions for themselves. Thank you, Manni.
Thank you, Manni.
Yeah,
we wish you well on your poster.
Did we do too fast?
No, I think we did perfect because we have about 25 minutes for any questions. And I think the themes of, the reason we're friends is, of course, we get along, but the real reason we're friends is that before we knew anything about each other, we agree on some of these core principles of oncology, which is the goal of oncology is to make people live as long as possible, as well as possible, with as little treatment as possible. All things being equal, you want the least treatment at the least price. And I just think our entire way we view it, and this whole meeting, is so skewed. But to me, the worst part about the meeting is the lack of opportunity for even any mildly dissenting opinion. The only diversity no one cares about in this field is diversity of ideas. That's the one diversity that's absolutely taboo, and so we're not presenting at the actual meeting, we're presenting it here, but we'll put it on YouTube and we'll reach more people than the whole meeting probably. But so
I believe the two of us are no longer much invited to many of the ASH kind of events.
He's no longer on the Cario Farm speed dial anymore.
To be honest though, and this is another problem, especially for trainees, for me it's fine. I have a great job, I live in San Diego, make good money, I have a rewarding career, but I completely get it for those new to the field who want to, and I can see that it's hard, how to balance this stuff. And I completely see why, people aren't more open about things. And I'm hopeful for a future where we can be.
So we've agreed to take any questions from you all, okay? And I guess the questions can be anything heme-onc related. We're going to try to keep away from, I don't want to talk about, all public health. I'm happy to give a lecture on public health policy.
If you start COVIDing me, I'm out of here.
Yeah, exactly. I don't want to talk about public health policy, and I don't want to talk about
So 6 versus 5 boosters, Vinay.
I titrate to troponin, but okay, go ahead. Yeah, go ahead.
It's a genuine question. I wonder what is it about myeloma that's different from other indications? It seems like the perception is that FDA has approved almost any drug in contrast with FDA saying
Yeah. Okay, it's a good question. One is I do think we picked on myeloma too much. We should have been a little more balanced, but honestly, we put together these slides a few hours before. So we didn't have much time.
We're busy. I was on call last week.
We're busy. Two. I do think that, the FDA, I do think in myeloma, we have to admit that there have been more active drugs in the last 20 years. If I actually had to, I have to admit, I think myeloma has had more progress since 2003 than MDS, for instance. In MDS, what have we really had? We've had, lenalidomide and 5q-, which affects almost no one, and we've had venetoclax. We've had very marginal improvements in MDS. MDS may be in a tougher disease. Myeloma is and the other thing is, myeloma from a drug development standpoint has a lot of advantages. It's incurable, which means anyone who ever gets the label will have the label forever. The median OS is now over 10 years, which means you treat them for at least 10 years. And the average cost per year per patient is like $700,000 because all the drugs are given in combination. So even though the annual incidence of myeloma is a low and it's considered a rare cancer, it makes a huge amount of money. And that is reflected in university programs and sort of an enthusiasm of drug development. So I think, and I also think there have been some real biological advances. Ken Anderson did do good work with PI. With proteasome inhibition. And, IMiDs was a great serendipitous discovery by Barlogi and Jayesh Mehta and others. And so, we pick on it too much, but I think it reflects both some of the best of oncology and some of the worst of oncology. truly active drugs, but also bad trials, conflicted things, and a lot of people make a lot of money.
It's also the one field that, like, right, there's this IMWG that does lots of good. They have the complete power to change the definition of an active cancer.
Yeah. But CLL, they could change, they could make MBL. It's like CLL is defined as a monoclonal B-cell lymphocytosis over 5,000. But they could make it 4,000 or 3,000.
But the difference is they don't mandate treatment where they do in myeloma, which is a quad and auto and red forever.
They could have interpreted that study and say give treatment.
They could,
so there's also some culture to it, I think. There's a cultural aspect to CLL. CLL in many ways more historically had some traditional values for many, many years. Myeloma has really had, it's a nascent field prior to 1990, really. I mean, you had one drug from 60 to 90. You had melphalan, which is still the most potent drug in the field. Even more potent than just crank up the dial. Okay, that's my thoughts. All right, okay. Any other thoughts? Okay, Eduardo.
What do you think about, well, you didn't talk about it, you had some slides, but what do you think about surrogate endpoints like MRD and myeloma? Because everyone's talking about...
Well, you talk about it. Do you have slides on that?
Yeah, okay.
Go do some MRD. Do some surrogacy.
You want me to do it? Okay.
I don't.
Well, okay, I'll go to my slides. While I go to the slides, let's do another question. Yeah, you in the back.
I was just wondering, just given the state of the field and how studies are getting done, how do you recommend making sense of the data, just given the...
So, I always say that, I think that, I always say that, the FDA is not doing what I want them to do. I do think with Marty, and there'll be an opportunity for reform in the next 4 years. There'll be a lot of shifts at FDA. So there's possible FDA will do better. I think the NCCN isn't doing what they want them to do. If I were in charge of CMS, I would make a single CMS rule that says in 2025, 6, 7, and 8, the percent of panelists with conflict of interest has to go from 60 to 40 to 20 to 0. I would make one CMS rule because all of these things, NCCN guidelines, it is a compendia that anchors CMS to treatment. If you change the incentive structure, here's what will happen. In 2025, a whole bunch of fellows are going to graduate, and 26 are going to graduate. Right now, if you're a fellow that graduates, the best thing you can do in ASH for your career is to go to all the ad boards going on right now. But if I change the CMS rule to taper that conflict of interest, the best thing you can do for your career is actually to not, because all the senior guys or senior gals are going to be conflicted out, and you're going to get to be the chair of the NCCN committee. So I think with very subtle rules, we could actually change the entire composition of these committees. The NCCN has tremendous power over deciding both the off-label use of all of these products that compel us all to use it. The next thing I would say is that if you're a reviewer or work in an editorial capacity, I think they should be incentivized to actually have Boston come with an editorial that says it's no good. This trial has got all these problems. Those are my thoughts on practical things to do. And then you all should be skeptical. I always say I will happily prescribe a drug even when I criticize the trial as long as the patient completely understands my concerns. I explain, for instance, brentuximab vedotin, 16 cycles maintenance in Hodgkin's lymphoma, the Athena by Craig Moskowitz study. It has a PFS benefit for $383,000, no OS benefit, and these people are largely cured.
And they can't play their guitar after it, though.
Yes, and brentuximab has tons of toxicity. And so I always tell people, look, I'm happy to prescribe if you want it, but here's what I got to let you know. 1, I can't promise you're going to be any more cured than you already are. 2, some people are going to recur no matter what we do. 3, all we know is it delays the time until we find out your cancer came back, but you're either cured or you're not cured. 4, it's going to be $400,000. And 5, you got a lot of nerve toxicity from this. So do you really want it or not? And they mostly say, no, I don't want it. Actually, I didn't even know all that. I just heard it's better and, shiny and new. And so that kind of stuff. What do you think?
Yeah, you said most of it. But what do you say to the critics who say some of your thoughts and process will stifle drug development and innovation in the marketplace?
Yeah, so I guess I would say that I 100% concede that there is some relationship between incentive and bar and number of trials being done. In other words, the more you pay people, the more loot you make from making drugs, and the easier it is to make that loot, more people are going to want to be in the drug business. 100% true. There's also the other axis of it, which is how effective are the products. If you set certain incentive structure, you will get the Gleevec of the world, you'll get the bortezomibs, but you might not get the melflufens and selinexors. What I want to say is that in the United States, over the last 15 years, we've thrown the dart on the wall, and we have a certain amount of incentive, and we have a certain amount of benefit. We have no idea the shape of the curve. If we make it harder to get drugs to market, we have no idea. Are we going to lose the Celis, or are we going to lose the Gleevecs? We have no idea what the shape of the curve looks like. That's an empirical question no economist can answer. So my rebuttal to this idea of innovation is that, yes, there's gold and there's fool's gold. I don't know how much of both we're mining. We've incentivized mining. We're getting tons of mining. A lot of it is fool's gold. There's real gold too. Trastuzumab deruxtecan. I think that's real gold. Nivolumab in Hodgkin's is real gold. The Swag is good. Ibrutinib is a great drug. I mean, I recruited patients with Wiesner on the phase 1 of ibrutinib. It was a great drug. But, how much better is acalabrutinib? It's better tolerated. How much better is zanubrutinib? Better tolerated. But is it really that much better? I don't know the answer. And so I do think that there's this entire curve of innovation. Meanwhile, if you want more drugs, there's a simple way. Right now, CAR T is 400 grand a bag. Make it 800 grand. If you make CAR T 800 grand tomorrow, you're going to get more companies going into the space. So we also could give more money to companies, but we don't do that. So why do we think the spot on the curve we are right now is optimal? We don't know. So I think that should be explored empirically.
Other questions?
Yes.
Actually, so I'm not a hematologist, I'm an epidemiologist.
Oh.
I work for a company that focuses on medication management. One of our focuses on de-escalation. I think Aaron in a tweet recently talked about de-escalation of therapy. And so one of the things we're finding is...
How are you going to make money from de-escalating?
It's about preventing medication management, about preventing hospitalization.
Got it. Yeah.
And one of the things we're finding is like when the population becomes typically use our technology, pharmacists reach out to providers. And we've seen that oncologists are very tough to accept our recommendations. So I was just, maybe like a comment on just sort of like that, sort of like issues in population health.
Well, nobody wants to be a doctor to have someone else tell them what to do. Okay. But I've been sympathetic, we always complain to each other about, prior auths and phone calls and all these things. But I also, we want to be able to practice freely. So I think that's one reluctance among doctors. But I do think we also have to admit that a lot of what we do is excessive and unnecessary and, could be deprescribed. Now, if I were cracking into deprescribing, I would try to sell it as patients who undergo deprescribing or reducing dosing and these kinds of things, they feel a lot better or something like that. That's how I'd approach it from a patient quality of life standpoint. Yes?
I manage a lot of oral chemo patients, and Selinexor is one of the medications I'm ordering. I realized and I find out a lot of times physicians actually spend a lot of time in proportionally talk about the progression-free survival, overall survival benefit, but very little talk about side effects because that's what patients care, right? Or how long I'm going to live. But then when side effects, so I have a lot of time when the patient actually transferred to me, I always make a joke about Selinexor. I said I would give Prasad, because one medication you get 5 attached to it. You're going to sulfur, olanzapine, templates, right?
Yeah, Selinexor.
It's like give Prasad.
Yeah.
Give 5 more. Just celebrate.
Yeah, when there's whole reviews written about managing toxicity of a drug, it's probably not the best drug, Yeah. I mean, there are.
But you're missing one thing from your basket. Yeah. The cinnamon. Yeah. Where's the cinnamon? Okay.
I just realized, physicians want to do, you guys want to do good, but I just feel like in the head, it's focusing so much on the efficacy of the medication, but the very little time of the safety, and then when patients realize that they don't want it.
It's hard. In defense of physicians, and I'm a pure clinician, it's hard. I mean, we got the patient in front of us who's usually dying of a cancer. It's hard, and we're not thoroughly educated enough in understanding some of these key things. While it's easier for us to just, and we also have like 10 minutes for this whole complicated thing. So,
No, that won't change it. I think the core problem is that, with the exception of this dialogue, you're not going to hear anything like this.
Nothing to that.
You're not going to hear anything like if you were a fellow coming up in this field. And there weren't social media, which there wasn't about 15 years ago. These ideas are completely not appropriate. They're not going to be at conference. You're not going to hear this kind of pushback. And of course, in Europe, they've always been different. In Europe, they have a different view of health insurance. The goal of health insurance is not just to pay for anything that we can pay for. It's to pay for health things that we should pay for. So Europeans have always been more reluctant to embrace the American standard. But it's increasingly difficult, I think, because they have the FOMO, fear of missing out, I think, in Europe. And so often in the Netherlands and for instance, I gave a presentation on olaparib in pancreas, germline BRCA mutant pancreas in the Netherlands. It was already being covered. I gave the presentation, they removed it from coverage in the fall of that year. So that even a country like the Netherlands, which has extremely stringent health technology assessment reviews, can be sort of caught up in this US mentality. The US mentality has led to good. Had it not been for our sort of profit seeking, we would not have so many, some of which are effective drugs. But we also, I think, are currently way past the tipping point. we're just doing so much stuff for our patients that doesn't make any sense. And your point about like the time to explain things, I'm not sure what it will take to do that. I think that's why, your job is important. You're doing a good job. And like, I'm...
Not all oncologists have oncology conferences.
Correct.
But that's fact, because our physicians really appreciate it. Because
You know what they have? They have more renal failure in their clinic because they're dosing it. They do! They're dosing methotrexate inappropriately and they're not checking levels. I'm like, what the fuck are you doing? Where's the pharmacist? You need somebody to watch this. Okay, go ahead. In the baseball hat.
I like the hat.
I'm from France.
Oh.
Different system. So you predict that the FDA, or maybe a different organization, in the US would start making value assessments.
No.
And you think they would be better than either payers or physicians in making these assessments. So you think that it's not the culture of the US, they're not going to go there, and if they did, they would actually not everything as good as the European HTA and so on.
Yeah, I guess I would say that I think in the next 10 years it's unlikely, but eventually it's inevitable. Why do I say that? I would say that, when the Roman Empire ended, in the capital city, if you lived in Rome, 50% of the days were Roman holidays in the capital city. In this country, when the empire ends, it will be when healthcare spending is 50% of GDP. We're at 20% of GDP. Switzerland, what are you at? You're at 13% GDP. No society can exist solely to fund their own healthcare. That's the point, that's the breaking point. But we're 20%, we're going to be 22% and 24%. There's no lever in the entire system. Everyone thinks it's the payers, it's not the payers. There's no downward lever. Like the payers actually make more money the more we spend on healthcare in the long haul. So we're going to spend more and more on healthcare. Only when we reach maybe 25, 30%, when people feel that their paychecks are stifled, when they feel more frustration, when they vote more erratically, will there be any opportunity to change. I agree with you. The only real solution is some HTA kind of thing. Give FDA comparative effectiveness authority, give them HTA, not pay for some of these things, say no. That's people should have, I believe healthcare is a human right, but that doesn't mean anything you want. It means the stuff in healthcare that's value-based and cost-effective. That's a human right. Everything else is gravy. You want to get, a CAR T for MGUS? Pay out of your own pocket. So that to me is the right system, some sort of, Germanic system where there's a public-private sort of interface. I think we're not there in the next 5 years, or maybe not in the next 10, but eventually it is inevitable. If it doesn't go there, I think you're going to see severe disruption to society. That's always been my thought. Any thoughts on that? No. Okay. Yes.
Let's hear the MRD.
Okay. Okay. So.
What do we talk? 5 minutes left?
5 minutes, and that's a
I'll let you do it, Roger.
Okay. The use of minimal residual disease as an endpoint in multiple myeloma trials, and I presented this at the FDA at the hearing. Okay, so I said the same thing. I said the goal is longer, better life. I say MRD is a mistake in the front line. So let's be clear what's being proposed. Right now, you can already get a drug approved in myeloma in the last line based on response rate. What they are proposing as a rule change is to improve it in the front line based on an improvement in the fraction of people who achieve minimal residual disease or no detectable beyond a certain threshold of myeloma plasma cells on bone marrow biopsy at the end of the treatment. Okay. You can also fail to achieve a CR but have MRD negativity because you still have circulating monoclonal proteins. So we get that concept too. Okay. So number one, in order to evoke the regulatory authority to make MRD an accelerated endpoint, the FDA has to say that newly diagnosed multiple myeloma is an unmet medical need. That's the statutory language. My first point in presentation was I think it is inconsistent with the law to say it is unmet medical need because 4-year overall survival is now 90% in Perseus. The median survival is more than 8 to 10 years. It's not an unmet need when you have and you also look at the number of treatments. There are 17 regimens in the NCCN guidelines. There's 14 drugs in newly diagnosed. There's 20 FDA-approved drugs. In terms of combinations, we have 100 combinations. So it's not a dire disease, and there's no longer a lack of treatment options in newly diagnosed disease. In my opinion, it does not meet the legal requirement for unmet need. That's my opinion. Number two, if the FDA says it's an unmet medical need, that same logic will apply to type 2 diabetes with cardiovascular risk factors that has the same 4-year overall survival. In other words, they will sanction an unmet need for tons of conditions that they don't want to do that in if they want to be consistent. And they have to be consistent. That's the whole premise of regulatory agencies. Okay. Number two, the NCCN already acts before data. This is from Manni, who it's going to be published in like a week or two, where what he shows you is when the phase 3 trial data was released and when the NCCN added the drug to the NCCN recommendation. They're not using MRD here. They're typically using PFS or something like that, but they're already adding these drugs to NCCN before the phase 3 data. Now, NCCN, being added to NCCN means the US payers by law have to pay. Medicare has to pay, and most commercial payers follow Medicare, hand in glove. Number 2, MRD as a basis for accelerated approval will guarantee that unsafe drugs come to market. Because MRD as an endpoint will be assessed 1 to 3 years sooner than PFS. And novel drugs will be eligible for accelerated approval maybe 12 months after a trial begins. It can be assessed very rapidly. And fast approvals mean that toxic drugs will be given to newly diagnosed myeloma. For instance, CAR T was first given by James Kokendorfer against BCMA in 2014 when I was a fellow at NCI. The first report in the entire literature that CAR T can cause Parkinson's disease was in 2021. It took 7 years. If you start allowing all these products to jump to the front line of therapy, you will guarantee those some products that not healthy, but people with myeloma who have other options will be exposed to products that may have unknown safety signals. To me, if you cure a person with myeloma and they have drug-induced Parkinson's, you might as well be dead because it's it's debilitating. It's almost worse than death. And MRD will rush these agents to front line. We can already rush them to last line. We don't need to rush them to the front line. That's my argument. Number 2, it means that they come to market. In teclistamab, 14% have dose-limiting toxicities, but took 18 months to see that. Okay. Number 3, progression-free survival is not a surrogate endpoint for living longer, and MRD does not predict OS. And they're looking at the correlation between MRD and PFS. In the study, they had many analyses done by Landgren and the colleagues that showed that MRD had a correlation with PFS. But PFS doesn't have a correlation with OS, and MRD has no correlation with OS. Landgren's own analysis shows that drugs that improve MRD levels do not predict drugs that make you live longer in myeloma, newly diagnosed setting, in their own presented data. And Manni did a paper where he shows that the correlation between PFS and OS is 0.39, which is extremely poor. I can explain more about these correlation coefficients later. Okay. The whole talk at the meeting, they talked about surrogacy. They said, do people who achieve MRD negativity do better? Of course they do. That's a prognostic question. If you have a deeper remission, you do better. But the question is not that. The question is, do regimens with higher MRD rates later show improvements in survival? That's the surrogacy question. And here, all the trial level correlations are poor, and most of the variability in survival is not captured by MRD. It fails as a surrogate by their own stated metrics. Okay, number 5, I talked about the poor post-progression treatment. We really don't know in myeloma, when to give drugs. To me, this means even if the FDA says we're going to prove based on MRD, we're just going to watch those trials. If there's OS decrement, as there was with pembrolizumab, if there's OS decrement, as there was in Bellini, we will remove the drug from market. Even if they do that, that only captures OS harms that occur in the setting of subpar post-protocol therapy. There could be real OS harms in the US market that you do not catch in this way. And so drugs could come to the US market that result in worse survival, but in global trials you won't see that. So to me, that FDA has to improve control arm quality. And then for me, the biggest thing is a little Parkinsonism and neurologic damage will be catastrophic when you have to live with it for 15 years. A little neuropathy is really going to be devastating. Parkinson's, a little transverse myelitis, a little of neuropathy, like having permanent Bell's palsy and disconjugate gaze. It's going to be a game over. And then the last point I'd make is, here is that actually the advocates, every single speaker at the meeting said we should do this. There's only one speaker at the meeting who said we shouldn't. That was me, and I signed up for this time slot. Now, the advocates say that this allows patients to have access to the drugs. But that's not true. Every single drug that will be approved in the frontline setting based on MRD will already be approved in the last line setting. It's not about access, which is the FDA's job. It's about making the payers pay. The payer won't pay for frontline drugs until FDA puts the stamp on it. They need this not for access. The drug's already available. They need it for payment. It's all about money. It's not about access. I think that's a misnomer of the meeting. And then the last thing is we just published it this week. We looked at the financial conflicts among all the speakers. And I guess my point here is that there were a few people who are not myeloma doctors and who did not have money from myeloma-directed payments. but most of the people who spoke at the meeting are heavily funded by companies that make myeloma products and have specific payments for myeloma products. My point is that, to me, it's like a jury trial where everyone on the jury, is siblings of the defendant. I mean, it's not really a fair trial in these sorts of ODAC meetings when they stack the panel. So why are they asking, these people, the FDA themselves requested that people provide presentations. They're only asking the side that they've already decided. They're not letting it be a real debate, in my opinion. Okay, so that's it. Yes?
I think, I don't work for
Yes.
FDA, and part of this is Project Frontline.
Yes.
Where they're trying to say, we don't like you also for this stuff, late line, single arm approval, on overall response rate. So let's do overall response rate in a randomized setting, so at least it's an RCT.
Yes.
Additional approval in front line.
Yes, and then follow for PFS and OS, yes.
Yeah, but it's okay. ORR in solid tumors, and you do these phase 2/3, encourages pharma to do that RCT as the first approval, which you're advocating for. Might we see a first approval on MRD and RCT versus a late line single arm study? Like there's a trade-off here.
I would do the same Project Frontrunner, but do it in the last line first. Like, do randomized study in the last line before the front line. That's my view of it. But to me, Project Frontrunner is because they are angry with failure to complete post-marketing commitments. The Government Accountability Office has put out a couple of reports that they are not enforcing those post-marketing commitments. They feel the pressure that they need to enforce those commitments. Project Frontrunner is the best way to get out of this problem because you force them to enroll on the randomized study. You also give them more cash. When you get a frontline approval, you don't just make twice what you make with a 7th line approval. You make 7 times as much. Your sample size, your population is huge. So you give them an incentive to do the randomized study. That's what FDA that's what Rick, I think, is particularly thinking about. They have everything, Project Orbis, what's the project about harmonizing global efforts, everything's a project there. To me, the risk is that you will expose a lot of people with 15-year survival to potentially extremely toxic drugs. And so far, I think the first thing that will go through this project is CAR-T. CAR-T will be frontline in 3 years probably. But what's going to happen in 7 years? There'll be some drugs that, maybe a Karyopharm company that shows Celi Velcade Dex is better than Velcade Dex MRD in the front line. And now, and then try to get some support for that. To me, that's the dangerous part. But I agree with you that they right now they're frustrated that they cannot make these randomized trials happen. And this is their way to get around that, to make them do this MRD as part of a randomized study. I agree, that's part of their motivation. Yes?
The other comment I'll make to your point is we don't really need another trial. We don't really need another drug approval in myeloma.
That's what I say.
Which is like your first point, right? In addition to the patients, right, doing well, it also makes my job harder, which goes to your point, where I have to talk about 20 trials now because they never compare to each other. And I now need 3 hours to talk about all 3 trials because they don't answer my question. So that's my biggest frustration with all these outcome myeloma trials is that I have to spend, I don't even know how much time. And all my patients are asking about their maintenance and all these other things.
De-escalating therapy based on MRD is not now single MRD. They want arbitrary 1 or 3 years, so nobody knows.
Yes. They also don't know where to measure MRD, 10 to the minus what, how many cells, it's in what assay, how much to do flow. Also, myeloma is inherently a patchy disease, so how many samples do you need? What if you flow several samples? I mean, there's tons of problems with. That's probably why it's been borne out as a poor surrogate, is because, why is it called multiple myeloma? On original autopsy, there are multiple patches of myeloma. It's patchy. So you keep sticking the needle in looking for MRD. Some places will be MRD negative, some places will be positive. We don't even really know the variability in the measurement. It's got tons of problems, in my opinion.
Do you think a protein addresses that? Like protein MRD-based approaches address that?
I would say, but how are you sampling the protein? Serum-based protein?
Mass spectrometry-based serum protein, yeah.
It sounds like it avoids it a little bit, but I'm not an expert in how sensitive the assay is and those kinds of things.
I am a bias. Look at the snake in the grass. I work for the government that makes this assay.
I see.
And it's a blood-based assay, so it's sensitive beyond 10 to the minus 6.
Beyond?
So it's hard to compare because they're two different analytes, the cells versus the protein. Right?
Yeah. And what exactly are you doing mass spec on? The monoclonal protein or the free light chains?
We de novo sequence the mass spec the monoclonal protein, and then we interrogate a patient-specific peptide that is unique to the patient.
I see.
So you reduce the noise from the signal.
Yeah.
That signal peptide.
Well, I guess you will overcome the bone marrow sampling bias. You may have some other problems.
And then you can address the MD.
Yeah, interesting. I wish Raj was still here, because he'd be able to have some thoughts on this. He's smarter than me in myeloma. Okay, well, thank you all for coming. This has been a great 2 hours. Thank you for coming and spending your time with us. Appreciate it. Thanks to Aaron.